we're going to be doing a continuation of the healthcare delivery talk from yesterday and going into more detail. Our speakers are going to cover the data, challenges in diverse healthcare settings. We're going to be looking at the economic and the payer perspective, and we have a very rich discussion planned for you. Let me introduce our speakers. Our first speaker is Landsdorp-Vogelaar, who is Assistant Professor in the Department of Public Health at Erasmus and a Senior Modeler for the Colorectal and Esophageal Cancer section in the department. And I need a light. Thank you. She's been part of the National Cancer Institute's intervention on surveillance modeling and network known as CISNET since 2003, and her modeling work informed the 2008 United States Preventive Services Task Force recommendations, the Medicare reimbursement decisions on CT colonography and stool DNA screening, and also, importantly, the Dutch National Colorectal Cancer Screening Program. Currently, her work focuses on explaining colorectal cancer disparities and on individualizing colorectal cancer screening and surveillance recommendations. Our next speaker, who is Dr. Greg Fero, who is going to be talking about the challenges in diverse settings, and he serves as a consultant to the Jackson Laboratory on education issues. He's also an associate editor for the Journal of Medical Association and is a member of the National Academies of Science, Engineering, and Medicine Roundtable on Genomics and Precision Health. He is board certified in family medicine and currently sees patients at Four Seasons Family Practice in Fairfield, Maine. And he spent the last week digging out and digging under massive amounts of snow. So we're welcoming here to our spring-like weather. He's formerly a senior advisor to the director of the Genomics Healthcare Branch in the Office of Policy Communication at the National Human Genome Research Institute here at the NIH. Yuri Ladbaum is our next speaker, who's going to be talking about the payer economic and cost-effectiveness perspective. He is a professor of medicine in the Division of Gastroenterology and Hepatology at the Stanford University Medical School. He is a member of the Stanford Cancer Institute. Yuri directs the GI Cancer Prevention Program and provides clinical care to patients with Lynch syndrome and other hereditary cancer predisposition syndromes. He oversees Stanford's Colonoscopy Quality Initiative, and his research interests include GI cancer prevention and risk management, risk stratification, cost-effectiveness analysis, and health services research. We have two very eloquent discussants. The first one is Ned Kalange, who is president and CEO of the Colorado Trust, which is a grant-making foundation dedicated to achieving health quality in all Coloradoans. I think that's how you say it. Is that correct, Ned? Health equity, thank you. He is an associate professor of family medicine at the Colorado School of Medicine, University of Colorado, Denver, and an associate professor of epidemiology at the Colorado School of Public Health. We're very fortunate to have Dr. Kalange because he serves on the National Academy of Science, Engineering, and Medicine Health and Medicine Division, it's a mouthful, which is previously known as the IOM, and on the board of the Population Health and Public Health Practice, and the Roundtable for Promoting Health Equity and Elimination of Health Disparities. He is a member of the Committee for Evidence-Based Genetic Testing, and I'm very happy to say the report is going to be released in March, next month. He served as the co-chair for the Genomics and Population Health Action Collaborative, and he's a past president of the USPSTF and a member of the Centers for Disease Control Task Force on Community Preventive Services. Ravi Sharp is our second discussant, and it brings a different perspective, and he's the Associate Director of Clinical Cancer Genetics and the Assistant Professor of Medicine at Northwell Health and Hofstra University School of Medicine. He's a gastroenterologist by training with a clinical focus on the care of patients with hereditary GI cancer syndromes. His research interests are that he conducts comparative effectiveness research focused on genomic medicine and translating evidence to clinical practice guidelines. So please welcome this really, truly wonderful panel. You just press down. Yeah, I think so.
Thank you very much. I hope this reaches. Can everybody hear me? Shouldn't be wearing.
Now try.
Is this better? Yes. Well, thank you very much for the invitation to present here to you today. I must admit I've been very impressed by the overall high quality of all speakers and presentations. So I sincerely hope that I won't disappoint you this morning. Thank you all very much for being here this early. Before I start, I want to make two disclosures. First of all, I am from the Netherlands. You may have heard of this great small country that has petitioned to be second after America's first. If you haven't, come to me in the break and I'll send you the link. But what I'm trying to say with that is that I'm sometimes maybe a little naive on how the health systems work here in the U.S. versus what I'm used to in the Netherlands. I have been working and doing research in the U.S. for, well, almost 13 years now, or 14 years now. So I know a little more than when I started, but still I might be somewhat naive sometimes. And the second disclosure that I would like to make is that that's maybe an even worse one, I'm a health economist, which doesn't mean that I'm only about money, but it does mean that I sometimes take a little different perspective. I really look at it from a population's perspective rather than the individual patient perspective, and that sometimes leads to different choices. In the end, what I'm trying to get is good value for money, and I think that that's what everybody wants in the end. So I've been given the rather broad title CISNET Comparative Modeling, and I feel myself as being sort of a representative of the CISNET Consortium, which is a wonderful consortium that has been around since 2000, and which I'm going to tell you a little bit about more. But I can imagine that people, after seeing the title, were a little bit wondering where this presentation may go to, so I made a little outline. First, I'm going to give you a short introduction on CISNET, on modeling in general, and on comparative modeling. And then I'm going to try and explain what decision modeling is all about, using our own model, the miscan colon model, as an example, and trying to take you through making that black box maybe a little bit more transparent. That's my overall aim. And then I'm going to present some results of cost-effectiveness analysis that we've done on universal testing for Lynch in colorectal cancer and in endometrial cancer using that miscan colon model. And after that, I hope that you get a better idea of what we can do with the model, and then I'll start with some suggestions for questions that we could use the model in the future to address some of the questions that have been raised here during the last day about things we need answers on. So CISNET, what is CISNET? Well, CISNET stands for the Cancer Intervention and Surveillance Modeling Network. And this is a consortium that is sponsored by the National Cancer Institute, and we have the founding father here in the audience, it's Ravi Sharp. And it's a consortium of modelers on breast, prostate, colorectal, lung, esophageal, and now also cervical cancer, which was originally formed in 2000, although some of the cancer started later. And what these modelers try to do is use surveillance data and use their simulation modeling to guide public health research and priorities. And so to give you a little bit of idea of what we've already done using those models is, first I want to see is why do we need those models? Why am I so passionate about the models? And why do I think that we really need those models to address questions? Well, first of all, let me start by saying we need trials as well. The first thing we need is trials because they are indispensable to determine the effectiveness of interventions. However, we also know from trials that they're expensive, they're time-consuming, and sometimes trials, especially randomized controlled trials, are no longer considered to be ethical because science has moved on. There's a mistake maybe there in the first place, but that's sometimes reality that we face. And so the consequence is, because of this expensive, time-consuming nature of the trials, it's impossible to evaluate all possible strategies in clinical trials. We just don't have the money. If we've shown that, let's say, biannual screening works, then also to show whether annual, triannual, or other strategies are also possible, it's just very time-consuming. And that's where models can be used. They take the evidence that's out there, and then they extrapolate to different scenarios, to different strategies. And that's why we need modeling. And this slide just shows you some examples of parties that CISNET has collaborated with to try and inform health policy. We've already heard that, for example, CISNET has been involved in informing the United States Preventive Services Task Force recommendations for colorectal cancer screening in the average population. We've worked with the Centers for Disease Control and Prevention to see whether if we would be able to achieve a higher rate of colorectal cancer screening, what type of capacity we would need for that, and they could compare that with the available capacity. We have worked with the Centers for Medicare and Medicaid Services to see what the cost effectiveness of newly developed screening tests is and how reimbursement should be set to make them cost effective. And finally, we've worked with the American College of Radiology, among others, to look at how well CTC is performing compared to the established colorectal cancer screening tests. And now I'm just going to show you some slides with results of these types of projects that we've done. So this is one of the first projects that I started with when I was a fresh PhD student, looking at what explained the trends in colorectal cancer mortality that we've seen. So we've seen colorectal cancer mortality going down. What could be contributed to risk factors? What could be contributed to screening? And what could be contributed to treatment? The second thing that we want to look at, okay, and what if you project forward? If we assume that risk factor screening and treatment continue as they were or stay at their current level, or if we were able to get better levels, and that's sort of the projections that we made with the models. Oh, the wrong way, sorry. Then for the U.S. Preventive Services Task Force, we knew, and they knew, that colorectal cancer screening was a good intervention. But what was the optimal age to start screening? What was the optimal age to end screening? And what was a good interval? So we simulated all these different kind of strategies, and every symbol on this graph is a different type of strategy. And we compared which strategies gave good value for the resources and the burden that was required with those strategies. And based on these results, the United States Preventive Services Task Force in 2008 recommended a stop age for screening of age 75, which had never been in any guidelines before. So that sort of is a way that modeling has informed the decision, because the model showed that going up to age 80 only had very limited additional benefit, but a large amount of extra burden and also the risk of overdiagnosis. And then finally, we did a cost-effectiveness analysis for CMS on the new technology of CT colonography. And what you see here, and this is quite a complicated graph, so I'll go through it quickly, is that the established screening strategies are all on the left here. But actually, the screening strategies using CTC, CT colonography, are all the way on the right, which means that they're way more expensive. And that's sort of what we showed, that at the current cost, those strategies would probably not be a cost-effective option for colorectal cancer screening. So if you can do all these wonderful things with modeling, why then do we need CISNET? And why do we need what we call collaborative or comparative modeling? Well, a model, especially one model, is only one answer. And what we knew from literature is that different models sometimes gave different answers. And that's because, as George Buck said, all models are wrong, but some models are useful. So we don't always know the exact thing because data might be lacking. But if modelers work collaboratively, they can try and identify the best data available to inform their model. They can discuss why they are using one set versus another set and how to improve their model. And they can also learn from each other's expertise. Then still, and that is still what we're experiencing in CISNET, despite we agree on certain data sets, there are still several ways you can use a model and replicate those data sets. So there are structural differences between the model, and sometimes we just don't have the information to inform that. Nobody knows how long it takes for an adenoma to develop into colorectal cancer, because if we see an adenoma, we take it out. We're not going to wait until it gets cancer. And then we don't know how much heterogeneity there is, et cetera, et cetera. And all those assumptions will make a difference in the end on what will be the optimal strategy. So by using multiple models to address the same question, this serves as a sensitivity analysis on what the underlying structural model assumptions are. And by using SysNet, putting the models together and making them collaborate, this is what we've done exactly. And if we see that the models give different answers, then we have identified a priority research area for where we need more data. If the models, despite being different, give the same answer, then that adds extra credibility to the results. And that's why we need SysNet. And we've also used SysNet to make models more transparent. So there's standardized model profiles, and we've developed new methodologies to describe our models so that people become more aware of what the possibilities are with modeling and how they are used. And this is an example of where comparative modeling has shed some light. If you see, these are two models, the MISCAN and the CircSpin model from the SysNet Colorectal Cancer Group. And what you can see from this picture is that the absolute costs for and benefits of colorectal cancer screening in one model versus the other model are quite different. But you also see from this graph that the question at hand that we had here is CTC cost-effective compared to the general test, was actually the same in both models. So the absolute level of cost-effectiveness might differ between the models, but both models consistently concluded that CTC at its current cost was not cost-effective. So that is how comparative modeling helps. Okay, that's a little bit about modeling in general, and I'm assuming that this still is all a little bit of a black box. So now I'm going to show and try to explain how our microsimulation model works, the MISCAN colon microsimulation model. Well, first of all, our model is different in some respect to most models out there in that it's a population simulation model. That means we model a dynamic population and not just one static cohort. And we model that population over calendar time. And we can incorporate risk factor trends, screening behavior, and diffusion of new treatments into that model, and then that model processes those data and comes up with outputs such as incidence, mortality, the number of tests being performed, and quality-adjusted life years gained, costs, etc. But what is microsimulation then exactly? Well, I always like to do that with these nice little faces, smiling faces to start with. When we have a population, everybody starts off, everybody's born at least as healthy. But as time passes, some people may develop disease, so they don't look as happy anymore. I made them red in this picture. And some people die of cancer or of other causes. And of course, new people can be born. So that's what you see in this graph. And then when time progresses even more people develop cancer, more people die of cancer, more people die of other causes because of age, et cetera, and more people are being born. So that's in essence what we do. We make a fake population that is representative for a certain population we want to look at. For example, the US population, but another example would be family members of people with Lynch, identified family members of Lynch, and we follow them over time, and then we have the opportunity to intervene and see what happens if you do the intervention. So this is sort of the way the MISCAN colon has been set up. On the one hand, we have what we call the input parameters. We put parameters on demography in there. What is the age distribution of the population? What's the life expectancy of the population? So that's the demography assumptions. Then we have the disease assumptions. What is the incidence of colorectal cancer? What do we assume is the dwell time between the onset of an adenoma and the progression to cancer? All those type of assumptions. What is the risk with this risk factor versus the risk with that risk factor? Those kind of things go into what we call the natural history part of the model. And then finally, we have the screening assumptions. How often do we screen? At what ages? What are the test characteristics of the screen, et cetera, that determine the effectiveness of the intervention. And then the model takes all these, calculates them through, and then outputs what has been the cancer incidence and mortality without screening, and then it also outputs the cancer incidence and mortality with screening. And just by comparing those two, you can look at the effects of screening, and by comparing several runs, you can look at the effects of changes in risk exposure and treatment. So that's in general how it works. But that still makes the box kind of black. So if we dive into that black box a little more, this is the structure of our model. We try to replicate the development of adenomas in the model. And what we do, as I said, people start off, are being born with a clean colon. But as they get older, there is a probability of them developing a small adenoma. And that small adenoma has a probability of progressing to a medium size or to a large size adenoma. And with increasing size, there's also the increasing probability that that adenoma transforms into a cancer. Well, we have a lot of adenomas in the model and only a few cancers, so there's also adenomas that don't make it to cancer. Then if we have this cancer, it starts off being a localized cancer, not yet giving symptoms. But then it starts to progress. And with progression, the probability of it giving symptoms and being diagnosed increases. And that's what we call the clinical cancer phase. So the preclinical cancer phase is the cancer that's there, but it's not yet giving symptoms. And when it starts giving symptoms, it's being diagnosed, and that's when it's called the clinical cancer phase. And then depending on the stage in which you're diagnosed, depending on your age, depending on the localization of the cancer, you either die of colorectal cancer or you die of something else. And then risk factors influence the onset of adenomas. Screening influences the adenoma and preclinical cancer phase because it can detect them and remove them, or because it finds cancers early with better prognosis. And treatment impacts the survival after a clinical cancer diagnosis. And as you see here at the bottom of my slide, there's a lot of information that goes into these models, and we try to synthesize the information from several different data sources. So that gives you a little bit of an idea of the natural history of the model. So how does it work? Well, first in the model, the demography component starts. And what it does, based on the input that we put in, what is the age of the year that a certain person is born in? And then after that birth, it simulates, okay, at what age will this person die, depending on when he was born. So it's all a basis of probabilities. And that way, we generate what we call a life history without colorectal cancer. Once we have that, the model starts simulating adenomas. And I'm just putting up an example here with 2 adenomas. And because of scale, it's pretty early on, but that makes it easier for me to show it graphically. Usually adenomas don't start so early in life. But let's assume that this is a very slow-growing adenoma. So it starts off as a small adenoma, but it's not until late until it becomes a medium adenoma. And then finally, that person dies of other causes before anything happens with that adenoma. But then this person develops a second adenoma, which is actually much more progressive. And then that adenoma quickly becomes medium, and from medium size becomes a preclinical cancer and a clinical cancer, and causes death from colorectal cancer. Then what the model does is has this life history without colorectal cancer. It has the individual adenomas, and that is being combined into a life history with colorectal cancer. And what happens is that because of those adenomas developing into cancer, this person dies of colorectal cancer before he would have died of other causes. And so you have life years lost to the disease. And the model knows this. So this is what we can count. How many life years have we lost to the disease? This is all in the absence of screening. Now what happens with screening? What I've shown on this graph, or this slide, is again that same life history that we saw at the bottom of the previous slide, so the combined life history with colorectal cancer, and the 2 individual adenomas. So what happens if we do screening? Well, let's say we do a screening intervention at a certain age, and let's assume, for now I always like to give the good examples, let's assume now that this screening test is really good and it finds both the adenomas. Well, what happens is that this adenoma will be removed and that adenoma will be removed, and if it does it well, then you no longer have adenomas. And if you no longer have adenomas, you no longer develop colorectal cancer, and so you're adenoma carcinoma free. You don't die of colorectal cancer, but you rather die at the age of other causes, and you have your impact of screening. As I said, I like to present the good examples, but the model also has the bad examples. People could die of the screening test. So they would actually have life years lost because of screening. People could have a screening test, but it would miss the adenoma that causes cancer, so there's no benefit at all, only the burden. Or people could be diagnosed with a cancer that would not have caused symptoms before death of other causes and now is being overdiagnosed. All those things are in the model and are taken into account because we model this natural history. Our model, in general, is a model for the average risk population. And now, because we want to do some universal testing for Lynch, we tried to adapt it for a Lynch population. And we did that in a little bit of a crude way for now, but we wanted to simulate a cumulative colorectal cancer risk of approximately 30% by age 70 and 50% lifetime, and that's sort of to get an average over all mutations. And we modeled this higher risk by assuming a 10 times faster progression of adenomas compared to the general population and a 2 times higher adenoma onset than the general population. So these were the two crude assumptions that we made. We didn't make any difference in the stage distribution, relative survival, or other cause mortality for now. And I know that these are simplifying assumptions, but that's what we do as modelers until we know more. And this is sort of the graph of the simulated cumulative risk of colorectal cancer by age. And one thing I noticed when I looked at this graph is that the risk at the younger ages is somewhat too low, so that's a thing that we could improve in future work. So how are we going to use this model to determine the cost effectiveness of universal testing for Lynch in colorectal cancer cases? Well, we worked with Nancy Baxter actually to set up an algorithm for universal testing, which is based only on patients with colorectal cancer under the age of 70 years. And these people, or these tumors, I should say, are offered IHC testing for MMR proteins. If the IHC is intact, that's the end. If there is a loss of MSH2 or 6 or PMS2, then those people are considered possible Lynch. For those with a loss of MLH1, there is the next step, which would be the test for BRAF mutation. Again, if that's present, that's the end. If it's a BRAF wild type, then there would be another test, a methylation test. And if there would be hypermethylation, it would be considered sporadic. If there would be no hypermethylation, we would consider it a possible Lynch case. And now, how would this flow of patients go through this? This is based on the research by Nancy Baxter. If we start with 1,000 patients that are diagnosed with colorectal cancer under the age of 70, we would have 850 people with their IHC intact, 133 with a loss of MLH1 expression, and 17 with a loss of the other expressions. If we would test those 133 with MLH1 expression, then we would find 48 with a BRAF mutation and 85 with a BRAF wild type. And if we would test those 85, we will get 57 cases that would be hypermethylated and 28 that would not have that hypermethylation. So in total, that would amount to 45 possible Lynch cases per 1,000 patients diagnosed under age 70. Okay, so then we have 45 possible Lynch cases. Well, then the problem is that actually we already lose a few of these patients before we get to the germline testing, because only 38 of them, and this is with patient navigation, only 38 of them accept the genetic counseling, and of those, only 30 accept the germline testing and next step. Of those accepting germline testing, 10 test negative and 20 test positive. Then the next step is to try and identify first-degree relative of those 20 people. And what we find is that on average, there is about 6 family members that can be identified per positive case. So that would be a total of 120 family members for those 20 people with Lynch. But only 62 of them agree to participate in genetic counseling, and only 58 of those agree to participate in germline testing. And then we end up with 58 people being tested, of whom 29 test negative and 29 test positive. And that's where the miscan colon model comes into place, because we now have a lot of costs for finding these family members, and now the model can try and see what the benefits are for starting more intensive colonoscopy surveillance in those 29 family members of those individuals. And that's sort of what makes this analysis that I'm going to present here today to you different from some of the analysis that Yuri will present later, where we have used microsimulation modeling to determine the effect of colonoscopy screening, which gives us the possibility to look at alternative screening intervention, not just 1 year or 2 year, but compare 2 year with 1 year, or even 3 years in a later phase. So that's what we've done. We've identified those 29 family members, and then we could use the model to determine what the costs and effects are of screening these people more intensely. So just to summarize this quite complicated graph that I showed you in the previous 2 slides, if you start with 1,000 colorectal cancer cases under age 70, you will identify 20 cases with Lynch, and those 20 cases will in the end result, this should be 29 family members with Lynch. So how much cost have we spent up to now? Here's the health economist in me coming back. So we started with IHC testing of all those 1,000 cases. Assuming a cost of $200 per IHC test, that already amounts up to $200,000 to start with. Then you do BRAF testing in 133 individuals with MLH1 deficiency, and that will amount to another $40,000. Then you would do methylation testing in 85 individuals at a cost of $295. That will amount to $25,000. And finally, you need patient navigation to try and get these people into genetic counseling, which costs $4,500 for those 45 possible Lynch cases that you identify. If you have 38 people adhering to genetic counseling, you get $6,600. And if you have 30 people adhering to germline testing, that will cost you approximately $24,000. These numbers are definitely not fixed. We don't know, and that's a big problem in cost-effectiveness analysis, what the exact costs for these things are. But in the end, if you put all these things together, you have spent over $300,000 for identifying and finding the Lynch cases. You don't have the family members yet. That's just for finding the Lynch cases. You've spent $300,000. Then you start again with that $300,000 that we had on the previous slide, and then you have to do genetic counseling in 62 individuals, which costs $10,000, and you do germline testing in 58 individuals, which costs $16,000, and then 29 people are positive and they need post-genetic counseling. So that adds up to a total of $332,000 to find the family members of Lynch per 1,000 colorectal cancer cases. So that's the upfront cost side. Now look at the downstream benefit side, and there's also some downstream costs there, which we'll also take into account. We looked at 3 different scenarios with our MISCAN model. The first scenario being usual care. And what I mean with usual care is that if there would not be any universal testing for Lynch, family members would not be identified with Lynch, and because they have now a family history, I'm assuming they will undergo 5-yearly colonoscopy from age 50. And I assume that 60% of them will actually participate in that colonoscopy. This is maybe an optimistic assumption, but I want to be conservative about the effects of universal testing. So it might be that a lot of these people actually don't undergo any more intensive screening colonoscopy, but it could be the case, so that's why I use this as the usual care scenario. In the second scenario, I'm assuming that there is universal testing, and it will mean that the identified family members will receive 2-yearly colonoscopy starting at age 25, or if they are older when they are identified, from the age they are identified. And I'm assuming that because they now know they have Lynch, and they know that they are at really high risk, and they have gone through all those steps, that they are very positive about undergoing screening, and that actually 80% of the people will participate in screening, rather than 60% without all this information. And then I looked at a third scenario, where identified family members do not receive 2-yearly colonoscopy, but they actually receive yearly colonoscopy, and compare those scenarios. So if we look at those 29 family members, and we would not do universal testing, they would receive 5-yearly colonoscopy starting at age 50, we would gain approximately 12.3 life years in these 29 family members. If we would do 2 yearly colonoscopies starting when they are identified or at age 25, we would increase the number of life years gained with the screening scenario from 12.3 to 20.4. So that's quite a big increase in life years gained with screening. However, going from 2 yearly colonoscopy to 1 yearly colonoscopy, the benefit is actually quite small. So there's very little additional benefit going from annual screening to biannual screening. If you look at the screening costs, because these people are such at high risk, 5 yearly colonoscopies in these people is actually cost saving. So the upfront colonoscopy costs are being earned back by the savings in colorectal cancer treatment later. So you have a decrease in costs. However, if you do 2 yearly colonoscopy, that's not quite the case, so you have an additional amount of costs of approximately $50,000 to do surveillance colonoscopies every 2 years in these individuals. And if you do yearly colonoscopy, the increase in cost is quite substantial. So you have about $223,000 extra for surveillance in these individuals. Now, if we add all these components together, then we have the 3 scenarios: usual care, universal testing with 2 yearly colonoscopy, and universal testing with 1 yearly colonoscopy. And we have the upfront costs here of universal testing, which of course are 0 in the usual care scenario. Then we have the net cost of the colonoscopy screening, and then we have the life years gained with each of these strategies. And if we take this as the reference, because it's dominating no screening, then you see that doing universal testing with 2 yearly colonoscopy is considered to be cost-effective according to U.S. standards, because it costs approximately $50,000 per life year gained. However, if you do it with 1 yearly colonoscopy, the costs are almost or over $400,000 per life year gained. So annual colonoscopy, at least from our model, does not seem to be cost-effective options compared to biannual colonoscopy. Because I wanted to know how robust the results were for some of our assumptions, I looked at some of the what I thought would be pivotal assumptions and changed them. So one of the things that I changed is that I have 60% participation with colonoscopy rather than 80% participation with colonoscopy. And you see that that has a big impact on the results. So that is something that we need to know. Does this change the behavior of people? Also, if we not identify 29 family members, but only 15 family members, how would this influence the results? Well, the cost effectiveness goes up, but it's still considered cost effective under $100,000 per life year gained. And if IHC testing would be $400 per test, it still would be cost effective. So this is quite good. We performed several additional sensitivity analyses, but in the interest of time, I will skip over that and go a little bit into endometrial cancer cases. So for endometrial cancer, we've done a similar thing. What if we do universal testing for all endometrial cancer cases? Well, to go through the slide again, we have 1,000 cases. In the end, 60 with a loss of MSH2, 6 or 2, PMS2, and 289 with a loss of MLH1 expression. No BRAF testing in this case because this is based on another paper. And we found, in the end, 78 cases of possible Lynch. If you test those 78 patients and assume the same acceptance of genetic counseling and germline testing, you will find 21 cases of Lynch, which is very similar to what we saw for colorectal cancer cascade. And then in the end, we would have 31 family members, which is very similar to the 29 family members, making the same assumptions again. And then if we look at the cost effectiveness of Lynch, it becomes very similar. If you do universal testing for Lynch in endometrial cancer cases, you get about the same cost-benefit ratio as you get for colorectal cancer because you find the same number of family members. But of course, there's one other thing that you could do, and that is the prophylactic hysterectomy for management of women with Lynch. And besides intensive colonoscopy screening, this is an additional intervention to prevent endometrial cancer in these women. We know from Meyer in 2009 that the lifetime risk of endometrial cancer is somewhere between 40 to 60%, but actually only 12% of Lynch patients with endometrial cancer die of endometrial cancer. So the lifetime risk of dying is only 6%. And the average age of diagnosis is about 50 years. Well, I tried to do some back-of-the-envelope calculations here, so it's very rough still, but based on previous calculations, we saw that we identify approximately 30 family members with Lynch per 1,000 index cases, and let's assume that half of them are women. So we have 15 women in whom we can do an additional intervention. Well, they have a probability of dying of endometrial cancer of 6%, so that means that one of these 15 family members is expected to die of endometrial cancer. And the average life expectancy of age 52 when they're expected to die is 33 years. And if you discount that, that's an economic trick, but we have to do that for cost effectiveness calculations. It means that you can gain another 15 life years in this population. Well, again, some back of the envelope calculations. Let's assume that $18,000 is required for prophylactic hysterectomy, which means that we have about $270,000 of upfront costs. Some costs will be prevented by having fewer people being treated for endometrial cancer, so there's a net extra cost of $130,000 and a net extra benefit of 15 life years gained, which amounts to approximately $8,400 per life year gained. So that sort of says that this is a cost-effective intervention we could do. But as I said, crude calculation, so we definitely need some more things there. But to summarize, compared with usual care, universal testing for Lynch in colorectal cancer and endometrial cancer, followed by 2-yearly colonoscopy screening, is very cost-effective. Universal testing for Lynch with 1-yearly colonoscopy screening is not cost-effective. And the only thing that these findings were especially sensitive for were uptake of colonoscopy screening. So that's something we need to keep in mind. Well, there's definitely a whole list of future improvements that I would like to make for this modeling. I want to look into more robust modeling of colorectal cancer in Lynch patients. We want to develop a natural history model for endometrial cancer. We want to add a comparator where Lynch cases are also identified in usual care, and we want to assume some higher other-cause mortality in Lynch patients. But these things being these things, I still think that modeling can really contribute to the questions that have been raised here yesterday and will probably be raised here in the future. We could look with our model at the comparative effectiveness of alternative universal testing scenarios that have been suggested. Should we use an age cutoff? What would be the impact on the costs, harms, benefits? And what if indeed the cases that you find over age 70 are actually associated with a lower penetrance? Those kind of things. We could compare IHC testing with MSI testing versus immediate germline testing. We could project not just the costs and the benefits like I've done today, but we could look at the harms. We could look at the quality-adjusted life years gained. Everything in the model is counted, so we know how many occurrences of every state we have. And we could look at stratification by mutation state. And maybe if you have PMS2 expression, then you should not get 2-yearly colonoscopy, but maybe then you get 3-yearly colonoscopy. Versus if you have MLH1, then maybe you should get yearly colonoscopy. Those kind of things we can address with the model. Of course, we can also help project the resource requirements needed because we have a population model. We can scale up to not just 1,000 patients, but maybe to a certain provider setting or maybe a population level. And we can look at alternative scenarios like has been suggested yesterday, looking at the comparative effectiveness of colonoscopy versus aspirin versus maybe a combination of the two to see what is the cost-effective intervention. So to finish my talk, thank you again very much for your attention. Universal tumor testing from our perspective is cost-effective, and I think Yuri will talk more about what other models have shown to help reduce the burden of Lynch-related cancers. Also, I would like to say that don't let the perfect be the enemy of the good. I think that universal tumor testing has been shown to be effective and cost-effective, and I'm sure that there are better ways or in the future to address this question, but that doesn't mean we should not do anything now. And finally, in the end, good quality universal testing may become a victim of its own success, because if this is being rolled out for several years, what might happen is that more and more families will have been identified, and then the yield of finding family members will go down, and then maybe in the end, it has to stop. But I think we're a long way from that hearing yesterday's discussion. Thank you very much for your attention.
David, would you mind waiting for the holding your, write your question, David, write your question down. No, we just hold it until the end. Thank you. It's my pleasure to introduce Dr. Greg Fierro, shorty, a 5-footer. And Greg is going to discuss the challenges in diverse care settings, and I hope this is a good setting for you.
Sure, that's down.
Yep. Okay,
great.
Thank you.
Well, very good, thanks. Well, I think the best way to introduce this talk is probably to say, and now for something different. So as a bit of a breather for all of you, I'd like to try a little in-house experiment. So if you could all just stand up for a second for me. Good job. So I would like only those folks who provide direct patient care to stay standing. Everyone else can sit down. Okay. So the next question is all those folks that provide specialty care, not primary care, can sit down. Okay. And all those folks who provide primary care but provide it in okay, well, there's one person. Okay, so you can stay standing, whether you're in an academic medical center or not. That was the next tier that I was going to ask about, which is to see if there was anybody here who actually saw patients outside of a major academic medical center. But we got there, to my point, a little earlier than I intended. So on from that. So disclaimers, I have no known conflicts of interest related to this topic. I speak for myself. I don't speak for my residency program or the Journal of the American Medical Association. And I don't really consider myself to be an academic investigator in any way, shape, or form, and likely after my talk you won't either. It's very daunting to be put in the middle of a bunch of quantitative folks. My talk is pseudo-quantitative. I will fully admit that. I'm talking in orders of magnitude, and you can definitely quibble with my numbers, and I will cower behind the podium. So this, I thought, should be a disclaimer, and then I actually realized it was sort of an education point. I was given the title for my talk of Diverse Care Settings, and depending on what type of audience you're speaking to, this could mean a wide variety of different things. I will tell you, for the purpose of this talk, it does not mean racial, ethnic, and cultural diversity and the impacts of that on a topic like universal Lynch screening. It doesn't really my talk doesn't relate to geographic diversity really in a meaningful way. I think you could have similar problems in an inner city environment or in a very rural environment, which is where I happen to practice. It does include something about socioeconomic diversity, and really, mostly my talk will focus on paying attention to the location and the healthcare ecosystem from which you're standing and how that impacts how you think about things like universal screening. So, outline for the talk. Where you sit matters. That'll be the first portion of my talk, trying to emphasize for you all that perspective really matters when you're considering a topic like universal Lynch screening. Then I'll talk a little bit about a pilot project we have at our residency program, which is funded by the Maine Cancer Foundation. Really isn't a universal screening program in the way you all are thinking about it, where you start with cases, but really is a family history-based approach for familial cancer syndromes. And then we'll talk a little at the end about the relationship of some of the points I'll raise to the topic of universal Lynch screening. So I'm used to talking to residents and faculty, and they all have the attention span of gnats mostly for long, complicated talks. They could never have sat through the modeling talk we just heard, which was fantastic, but their eyes would have rolled back in their heads. So I usually give my take-home points at the outset. So approaches to tackling familial cancer syndrome detection, universal screening or otherwise, really need to take setting into account from the outset. It is a critical feature for success. Without that, you're essentially doomed to failure from the start. Addressing structural issues, just putting in the sort of nuts and bolts to create such a program is necessary but not sufficient for success. And then finally, the last point, and this one is painful for all of us to contemplate, but consider carefully whether or not introducing a new complex series of potentially relatively low yield, and I know this audience isn't the one to say that to, interventions, whether this is the time to sort of try to introduce a high demand, relatively low yield intervention into healthcare systems. So, About this time in Maine, most of us spend time thinking about places like this. It is true, we had 48 inches of snow in 8 days. Monday of last week, 26 inches of snow with 40-mile-an-hour winds. I was literally snowed in my house with a plow truck in my driveway. But let's take this analogy a little further. So the folks you're after in your population, just think of them as the nice little shiny fishes swimming around the coral reef, and you're standing here on the beach. And you want to get to those fishes. You want to see them or catch them or whatever you want to do with them. So you are right now talking about developing the tools to get to that point, really. You'd like to be able to get there from here. And it seems extremely rational that you would develop tools like snorkels, right, to get to those shiny fishes. And that seems entirely rational from a perspective of standing right on that beach and looking into the coral reef. So hold on for a second and we'll get to my point. So back of the envelope calculations. In preparing for the talk, I thought, how can I sort of emphasize for you this issue of perspective? So not to pick on Kaiser Northern California, a fantastic organization. I went to their website and just went to their FAQ page and picked out some information about their environment versus our environment. So Kaiser Northern California covers roughly 4 million patients. For a point of reference for me, for Maine, we have 1.3 million inhabitants of our entire state. They have 71 hospitals in their system, 238 medical offices, almost 8,000 physicians, and 6 regional genetics clinics as part of their infrastructure. My residency program, 20,000 patients, give or take 5 or 10,000. We can't actually count them all that easily. About 100-fold less than Kaiser Northern California. 1 hospital, 3 medical offices, about 80 physicians. Now these are part-timers. There's 30 residents thrown in here, a few fellows, et cetera, et cetera. So the patient panels are much smaller, I would say, than general primary care practices. And we have 0 genetics professionals. There's a few folks in the state of Maine. I practice in the Augusta-Waterville area. It's a rural area. Maine Medical Center has a fantastic oncologist geneticist. Some of you may know Sue Meisfeld and her team. They are great, but they're an hour and a half away from us. So let's take it even a little further. So a vanishing species, let's talk about the solo practitioner. There are at least a few of those folks still in Maine. Patient panel sizes have gone now. There are about 1,000 patients per FT or internal medicine doc. That's about a 1,000-fold smaller panel than what Kaiser covers. They may go to 1 hospital. They probably have 1 medical office. A few, I guess, have a couple that they might go to. Maybe 1 physician is a solo practitioner. And what do they have for genetics access? Well, it really depends on where they are. As we heard the great talk yesterday by the folks from NSGC, we're making gains on access to genetic service providers, but there's still, I would argue, much like it was 15 years ago when I started thinking about this, a maldistribution, if you will, of where those providers are. So how does this translate? Now, here's a point where we could immediately quibble, 1 in 280, 1 in 500. It's not an order of magnitude. It's not 1 in 50, and it's not 1 in 500. It's somewhere around 1 in 500. Kaiser has 6,000 individuals they'd be worrying about in their patient population, roughly, affected by Lynch. My residency, maybe 40 individuals. That solo doc, maybe 2 individuals in their practice might be directly affected by Lynch. To find those folks, there's an economy of scale for Kaiser. When they put in infrastructure, they got 6,000 lives they're serving with that infrastructure. When my residency puts it in, they've got 40 lives. When that solo doc has to think about gearing up to handle Lynch and familial cancer syndromes, they've got a handful of folks. What about incentives? So in Kaiser, integrated healthcare system, long-term benefit from these modeling studies accrues decades potentially out in families. They will see the cost savings for this. My residency program, perhaps not so much. We focus on public and private insurers, not self-insured. The solo doc certainly is in that same position. And there are relatively few incentives besides doing the right thing right now in our healthcare system to make folks want to try to gear up to tackle this topic. And I think one of the things modeling can't help you with, you can get to the point where you understand whether or not something's cost-effective very elegantly. What often doesn't happen in these conversations is opportunity cost. Okay, so what do I mean? Well, this is a talk I we had last week at our monthly practice meeting from our hospital's prevention center, and they came to talk to us about food insecurity and its role in our practice environments. The USDA defines food insecurity as quote-unquote limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. And they presented some fairly robust data about how food insecurity drives up healthcare costs and results in poor healthcare outcomes. And then they put up this slide. Maine ranks first in New England for food insecurity. About 16% of households, roughly a fifth or so of our population. Among children, food insecurity rates are 23.3%, and in seniors, and I have a population of patients in my practice that are largely elderly, it's about 17% of seniors have food insecurity. There are tools out there to screen for food insecurity. About half the people who qualify for WIC in our state aren't on WIC, so there's an intervention in place. And they were making the argument that we should spend more time looking for food insecurity in our population. David Chambers raised the point yesterday about sometimes it is acceptable to not implement something, and I would argue that opportunity cost is one of the major drivers for that consideration. Food insecurity is about 100 times more prevalent in Maine than Lynch syndrome. So if you're a primary care physician, you're going to spend your time, which is very precious, thinking about gearing up to do something. Which topic are you going to tackle? And you may have heard a little problem that we have in our state with West Virginia. We rank right around there. Last year, we had 1 death per day due to opiate abuse. A lot of the care for those folks falls on the shoulders of primary care. And we've all been forced in my residency program to be X-waved. I could treat all of your opiate addictions with Suboxone if I needed to right now with my DEA waiver. I would say that if right now Kaiser were losing 4 patients per day due to Lynch, that would get their attention. And it's gotten our state's attention. There are now laws in place that mandate physicians look at a prescriber log every 3 months that's statewide for prescriptions every 3 months. And if you don't, they will fine you $250 per time you don't actually look at the prescriber log if you're taking care of somebody on chronic opiates. It's really quite draconian, and we're dancing to that drum. So that snorkel, which made a lot of sense from the beach, might even be necessary to get to the fish. To the folks I work with, it amounts to looking at the beach from here and thinking about whether the snorkel makes sense. They can recognize that the snorkel is important once you get to the beach, but if you're standing on the surface of the moon and you're facing all these other barriers, moving on to using the snorkel is a ways off, okay? So, not to say we don't think about cancer in primary care. We think about it quite a bit. We think about it at the population level, and we think about high-impact interventions, and we think about the continuum of care. People come back to me from seeing their oncologist geneticist and say, gee, I didn't understand anything they told me. Could you help me with this? So we spend a lot of time thinking about this, perhaps not as much as you all would like us to. So a little bit about the project we have. Does it run in the family? Basically, the Maine Cancer Foundation funded us to create a project that builds on infrastructure that patient-centered medical home, centers around nurse wellness visits for cancer family history, where we empower physicians. Anybody in our system can make a referral for a nurse wellness visit where the patient gets a packet to fill out before they come in, including their family history information. The nurse takes that packet, flushes it out during the nurse wellness visit, and then stratifies risks using a checklist sheet, basically, for 2 cancer syndromes, Lynch and HBOC, and then passes that sheet along to our clinicians who have a second tier of sheets to review the family history and perhaps meet with the patient, and then move the patient along. There are 3 components to this project. We had an educational component for our residents and our staff, as well as our faculty. There was a sort of a quantitative sort of measuring outcomes component, which is ongoing. And then there was the sort of building infrastructure in our office systems component of the project. This is a rather busy slide. It just basically provide you with a flow diagram of the process where providers or patients could self-refer, or the providers can directly refer to the nurse wellness visit. They can also directly refer to geneticists in the program. There's a family history review step for the nurses. There's a family history review step for the providers. And then there's a variety of dispositions in this efferent arm going from our providers to specialty care. So what have we learned in sort of setting up this infrastructure? We're now a year and a half into our pilot project. I think you wanted to hear about challenges, so I'm going to talk to you a little bit about what we've run against. So perception of relative lack of importance. So among our patients, providers, and institutionally, because of things I've already talked about, Lynch syndrome and HBOC do not bubble to the surface on people's minds. Patients, you know, I think one of the best examples of how they sort of vote with their feet is they'll say, gee, this is really interesting. Yeah, I have some cancer in my family. Give me one of those packets. I'll get back to you. Guess what happens? They don't get back to us. So there's not a sense of urgency unless the person's actually had cancer, and many of you live on the end of the funnel where people have had high burdens of disease. In the general primary care setting, there's not a sense of urgency among patients to tackle this topic. Providers, well, for me, it was a tremendous struggle to get 4 hours of curricular time for our residents in the space of a few months, and even more of a struggle to get our faculty to attend to this topic. I could only get 2 hours for them. They've got a lot that they've got on their plate educationally. Institutionally, we had great hopes. We were going to, as many of you know, I've been involved in family history and the Surgeon General's tool for a long time. We had great hopes at the outset of this grant. We were going to integrate the Surgeon General's tool with touchscreen laptops into our EMR system. Not so much. Our institution basically stonewalled us and said, you know, the interfaces are too costly. We can't possibly do this. We've got more priorities in our EMR system, like our allergy list we can't get to work. Sorry. Quality metrics. So I also had a role in the stage 2 meaningful use family history criteria. Yes, it's true, meaningful use did sort of drive a little uptick in family history and EHRs, but we don't have quality metrics. Right now, we're dealing with quality metrics around diabetes, hypertension, hyperlipidemia, et cetera, et cetera. There aren't quality metrics for this. So the institution, again, they're not getting paid more for this, not so much interested. So what's one way you can tackle this? You can widen the tent of what your program is sort of looking to try to capture. So we purposely, with this family history project, didn't focus on a single familial cancer syndrome. We sort of increased our yield by sort of including both hereditary breast and ovarian cancer and Lynch syndrome. And we also purposely included in our net weaker family histories. And some folks here are probably familiar with a few of these authors. And I don't know if any of them are actually in the room, but maybe. Weak family histories are fairly prevalent in the population, and there are meaningful evidence-based guidelines right now for what to do if an individual has a single first-degree relative with breast cancer at a later age, or a single first-degree relative with colorectal cancer at a later age. Earlier screening, perhaps more frequent screening, and certainly a change in modality for colorectal away from FIT and towards colonoscopy. So we widened our net to make it more relevant to our crowd. So educational needs. I will not belabor this point. This has been talked about for decades. Patient needs, provider needs, institutional needs. NHGRI has lately done a very interesting thing, having webinars for insurance company executives on topics in genomics. Critical that those folks at that level understand the importance of this topic, because without them, the infrastructure is never going to get in place. So just another example, recently we entered into a project with the folks at Force, she's back in the back of the room there, to try to bring peer navigators to rural environments, folks that have experienced familial cancer syndromes, to help patients in the population or potential patients in the population navigate the healthcare system and understand what familial cancer syndromes might mean to their families and themselves. This type of resource for rural environments is scarce, and I very much appreciate Force involving Maine in their pilot project with this. So reimbursement. Purposely, our nurse wellness visits already were in place, and we were doing them for diabetes, hypertension, hyperlipidemia. They are billable. So when this grant goes away, we still have an income stream for this process. And I think that's really important when you're thinking about developing infrastructure for this, particularly in the pilot realm, that from the beginning you're thinking about, okay, when this grant goes away, how am I not going to drop people on their heads with regard to the clinical services? And certainly it was also purposeful to not make this grant mostly about doc time, because they're the income generators, main income generators for a practice environment, and anything that can be offloaded from them should be offloaded from them, and it's a bonus if it's billable by another staff member. So obviously the USPSTF and the Affordable Care Act had a great effect, I think, for issues around screening for cancer, high risk and otherwise. The USPSTF breast cancer recommendations, for example, around BRCA testing and the teeth that ACA afforded to those recommendations. But these talks sort of write themselves, I think, as I'm thinking about putting them together. There's a great deal of uncertainty right now about the implications the new administration will have on the Affordable Care Act, and I think this will all come back, if it goes away, to give us headaches. So another topic that I'm not going to spend a ton of time talking about because it's been beaten to death are issues around communication, system fragmentation, and EMR issues. Again, the talks write themselves. This was a medical economics that came out in October of this year. Subpar systems, physicians' voice frustrations. We have tremendous problems at our institution. Despite being one of AHRQ's first funded hospitals that adopted an EHR back in 2004 or something like that. We've had an EHR for a rural hospital for a long time. It is still a mess, okay? Sue Meisfeld has great problems at her institution as well with communications. We were talking about this talk before I came, and she mentioned how it's extremely difficult to get the gastroenterologists, the OB-GYNs, the pathologists, everyone sort of on the same page about any individual case moving through their system. Again, subpar systems improvements in communication. So purposely in our pilot project, we tackled that. So in the afferent arm, sort of coming back into from genetic services to the PCMH, we're purposely working on issues around communication, taking the 7-page genetic consultation note, which is often fairly complex, to say the least, for the primary care person to digest and put into their health maintenance plan and their EMR, and restructuring that so that it's easily translatable to care plans, and those things, again, that nurses and others that deal with care plans tackle in our settings. We also are trying to develop something that amounts to, we're calling a debrief visit, not perhaps the best term, but where once somebody comes back from genetic services, they actually have a specific visit to talk about what happened at that genetic service visit in the primary care setting, in the PCMH, context of the PCMH, to populate things like the health maintenance plans in our EMRs for providing care. So, again, that's not universal Lynch syndrome screening starting with cases. I will tell you from a primary care perspective, it's rather and I suspect from a patient perspective as well, it's a rather hard pill to swallow that we're going to wait for cancer cases to happen before we start thinking about the topic. People come to us in primary care and ask about their family history, so our project really isn't universal Lynch syndrome screening. It's rather opportunistic sort of I don't even know, screening isn't the right word. It's opportunistic service provision, I guess, if you will. But I think a lot of the issues that we've run up against translate well to the issue of universal screening and some of the challenges that will be faced. This perception of relative rarity, particularly if you're developing infrastructure just for Lynch. Educational needs, we've heard about that yesterday from a number of different folks at all levels of the system, and it has to be educational content that is tailored to the environment in which you're working. I love the comments from there was a genetic counselor from UCSF who was talking about the robust online infrastructure they developed and these patient registries that people can upload their family histories into. And I'm thinking, Waterville, Maine, how many of my patients with food insecurity are going to be just rushing out there to use that type of infrastructure? The answer is not many. Reimbursement, key. I think the pathologist talk yesterday brought up the issue of the skewing of using IHC versus MSI. you know, that's just the tip of the iceberg here, folks. It really, really is, once you get out of a pilot grant-funded environment. And then subpar systems. This isn't unique to this topic. It's sort of universal in healthcare right now. In fact, I believe it was in the AAFP news bulletin yesterday that the current AAFP, I don't know if they call him president or whatever, the elected physician represented head of the AAFP, sent a letter to Tom Price about the challenges we have with regard to EMRs still in the U.S. and interoperability and real functionality for population health management. So conclusions. Same conclusions that I started with. Approaches to tackling familial cancer syndrome detection, universal screening or otherwise, has to take care setting into account, and you have to take these structural barriers into account. You know, you all live on that beach mostly. You don't live on the moon like I do. You are developing great tools that will work very well for those folks who live on the beach to get to the fish. You need to think about the gulf between the moon and the beach as well. Addressing structural issues is necessary but not sufficient for progress. And think carefully about opportunity cost and whether or not you will serve yourself better by waiting a bit, by trying to push out this type of infrastructure development when there is great chaos in our healthcare system, or would you be better in sort of doing your pilot project, learning more, and then thinking about sort of exhorting people in the moon to tackle your topic. So, I'm sorry, I'm glad I wasn't the last speaker because you'd all need Prozac. But I'd like to give thanks to a number of folks who provided me some good data, unfortunately a little too late to include in the talk from Maine Medical Center about attrition of people who have undergone universal screening in their setting. Many of the issues are the same that you've already talked about. Folks at the Jackson Laboratory that I work with on educational topics have provided some of the slides. The folks at Forrest who are now working with on their Project Plural, Maine General Health Prevention Center for their slides on food insecurity, and of course the Maine Cancer Foundation for being kind enough to give us a little seed money to start the pilot project that we have. So thank you all.
Greg, thank you very much for the reality of being in not being in an academic center, but the reality of being in real practice. I think we all needed to hear that. Our next speaker is Yuri Ladderbaum, and his topic is Payer Economic Comparative Effectiveness Research Perspective on Universal Screening.
Thank you, Erica, and the rest of the organizing committee. It's an honor. I've learned a lot so far. I think it's been a great program, and Eric introduced my topic. This is what I'd like to cover with you. I'd like to consider what we mean by universal screen. What is the universe? Who's contained in the potential universe for screening? What is the screen? And then what happens afterwards? I'll review some of the economic and cost-effectiveness analyses that have been published before, and thanks to Iris for a wonderful introduction. I think hopefully people will understand this a little better with everything that you went through. I'll give you a perspective from a commercial payer, and then I'd like to broaden our perspective to look at the context beyond Lynch syndrome. There's a cancer genetics revolution going on. This is a rapidly changing landscape. And then I'd like to consider what are the implications of a lot of this work to date for comparative effectiveness research in the future. So, the universe, the screen, and what happens later. How big is the universe? Well, this is 1,000 people, and what I'll show you is how this populates with people who have colorectal cancer during their lifetime. The statistics that have fed this graphic are in the bottom right. Lifetime risk for colorectal cancer is 5 to 6%. The median age is 68, so you'll see slightly more people under age 70 here than over, but about 50-50. Lynch is found in up to 3% of colorectal cancers, so 1 out of the 50 people here with cancer will have Lynch syndrome. And Lynch syndrome, I used 1 in 440 in the population. If it's 1 in 280, there would be a few more people here. But this is how it all fills in. So there are a bunch of people here who have colorectal cancer if you follow them throughout their entire lifetime. We're talking about finding those people with Lynch syndrome, and those are here in the bottom right. Just for convenience, I happen to show one person who has Lynch syndrome and has experienced colorectal cancer under age 70. Here's another person with Lynch syndrome who will not get colorectal cancer during their lifetime, or will not have it by the time we think about finding this person. So the moon versus the beach perspective, where do we sit, how do we find these people? Well, it's conceivable that one day we'll try to look for Lynch syndrome in the entire population. For the reasons that Greg mentioned, I don't think this will ever be an effort just to find Lynch syndrome. You could think about a day when we'll all have our genome sequenced for all the actionable things, and the question is, at what age do we do that, and what do we do with all that information? But we're not there yet, but we can think about that. We do infant screening now, so that happens. Consent there and the implications are completely different. So how do we find the asymptomatic people at high risk? Do we have to wait until somebody has cancer in the family? Among the asymptomatic people, you somehow have to cone down. So do we take a casual family history? Do we have strict clinical criteria? And we heard about how some of the traditional ones don't really apply anymore. Or do we go with more formal risk prediction models to try to figure out who then gets tested further? Or do we wait until somebody has had cancer? Do we try to find Lynch among those people with cancer? And when we talk about universal screening now, this is usually the universe we're talking about. People with colorectal cancer, people with endometrial cancer. You can ask whether we should include other cancers. And then the question comes up, are we talking about all ages, or do we somehow say people who tend to be younger, however you define that, maybe under 70? So those are the questions with regards to the universe. What about the screen? Well, it depends on what the universe is. If it's the entire population, we're probably talking about some type of gene panel for all, and probably should be beyond just a cancer gene panel, because if we're really doing it, we should do the whole thing, but we're not there yet. If you're looking at asymptomatic people who are at high risk, you first have to somehow screen them to find who the high-risk people are. And then the second intervention is to consider some type of germline test in them. If you're talking about people with cancer, you first have to somehow screen them. And is that a clinical screen, or do you go to the tumor? You could look at clinical criteria or prediction models. Those could lead to germline testing, or you could use those to select people for tumor testing and then decide who goes to germline testing. If you do tumor testing, we are usually talking about IHC or MSI. You can then do second-line testing to try to pick out the sporadics, BRAF, MLH1 methylation, and then comes the germline test, either second or third in that sequence. Or you could say, forget all of that. Once I have people with cancer, let's just do an upfront germline test on all of them, and you can talk about a narrow test or a broad panel. But what happens after the universal screen? What are the things that we care about? Well, for the proband, if you're talking about testing people with cancer, what follows once you diagnose them with molecularly confirmed Lynch syndrome, it's intensified colorectal screening. The intervention that we know works for gynecologic cancers is a prophylactic THBSO, and question about other measures. We do other things without clear benefit. For the relatives at risk, the key thing here is finding them, testing them, and doing the right things for them. We've heard a lot about cascade testing. We're talking about site-specific germline testing for the familial mutation in these patients, and then risk management as for the proband above in people who test positive. But key issues are, what is the uptake of any of this at the first pass, and what's the adherence over time with the preventive interventions? If you find people and you don't affect natural history, we're not doing anybody any favors. And what are the outcomes in terms of cancer, survival, but also other things? What is the balance of benefits versus harms? And this includes potential psychological harm, medical outcomes, economics, and other costs. And as Iris pointed out, the most ambitious models try to integrate all of this. All of them are approximations, but as we get more and more ambitious in trying to model all of this, we try to put in all of these variables. So now let's talk about the economic and cost effectiveness analysis work that has been done to date. The first set of analyses try to estimate a cost per mutation detected. So that just gets you to case identification. It doesn't look at the entire downstream set of consequences, both good and bad, that you should care about for a holistic assessment. But this is a very important place to start. And jumping forward a little bit, this is the type of thing that payers may think about. They often don't have the really long perspective. So they may say, how much is it costing me to find a Lynch syndrome patient? This initial study came from Europe. It uses European costs. And you'll see that the conclusions can depend on what type of patients are included. So these were 168 colorectal cancer patients. 43 were considered sporadic, late onset, so older individuals. 25 with definitive or suspected HMPCC. The cost structure is important. The conclusions in terms of health economics depend directly on what your assumptions are about costs. So in this particular analysis, IHC cost 50 euros, MSI 175 euros, germline testing 450 euros per gene. And you can see that there are various strategies here. PCD is pedigree or clinical data. Then you could look at that plus MI, which is microsatellite instability, or you could look at the clinical criteria plus IHC, or do both of the tumor tests combined. The number of people in whom you needed to do sequencing varied. There were a total of 6 people with mutations here. You could identify 6 or 5 of them, so perfect yield or high yield. And the costs range from about 900 to almost 4,000 euros per mutation detected. Is it good? Is this bad? It's honestly very hard to assess because it depends on what happens afterwards. But this is the beginning. A study from the Netherlands here asking the question of patients referred to Erasmus who had suspected Lynch syndrome. So there was already something going on here in terms of family-based suspicion. What happens if you use a risk prediction model to try to cone down on a smaller population to test on? Cost structure here, IHC and MSI both done together, 500 euros. Germline testing, 620 euros per gene, and at the time 3 genes were known and tested for. Now, the first line here is when you have essentially a very liberal testing strategy. It doesn't matter what the PREM model predicts. You basically say, I'm going to test everybody. So you end up doing 321 tumor tests. Everybody gets tumor testing. That leads to mutation analysis in 94. Eventually, 66 people are found. At the other extreme, if you say tremendously high bar, 40% probability or higher predicted that you'll find a mutation. Then you only do tumor testing on 31. You do germline analysis on 18. You detect mutations in 18. And the question in terms of the incremental benefit and incremental cost is what happens as you go from most strict to less strict to totally liberal. And that is the numbers here on the right. You go from finding 18 people to 41, 53, 64, 66. You can see that there are diminishing returns. Every time the increment that you find is smaller, and the incremental cost per that additional mutation detected goes up. So initially, it's about 1,600 euros per mutation detected. If you go all the way to the top and you say, I really want to find those last 2, I want to get all 66 instead of just 64, it costs you 20,000 incremental euros per each of those last 2 mutations detected. This is the type of analysis that is often done when you look at the incremental benefit between strategies. Now, for a U.S. analysis, and you can see that a lot of these things have changed over time because this model was designed to look at finding MLH1 and MSH2 only. So things change over 10, 15 years. And the model here was looking at MSI on all colorectal cancers or looking at just a selected group for MSI testing. The cost structure in the U.S., $295 for genetic counseling, $245 for the meeting for the initial screen, MSI testing $350, testing 2 genes, $1,950 at the time, and then sequencing a family member, $315. I know you're not going to remember these numbers, but I'm just showing them to you to set up what's coming towards the end, and many of you can anticipate. The costs for some of these things have fallen a lot. And what this shows is that if you looked at more liberal modified guidelines compared to the very strict Amsterdam criteria to decide who should have tumor testing. The incremental cost per gene carrier detected, $6,800. If you use slightly different criteria compared to the modified guidelines, $3,000. If you tested everybody compared to trying to select people, so this is doing MSI on all colorectal cancers, $50,000 per incremental case detected. Again, this is just at the level of what is the cost per mutation detected. We've heard about EGAP. They did a tremendous job assembling all of the known literature that informed inputs to a set of simulations, and then they undertook an analysis based on the output of cost per mutation. And the strategies that they looked at were the following. Looking at people who present with colorectal cancer, could one do germline sequencing for the 3 principal known Lynch genes at the time in everybody? Or could you do MSI testing to guide germline testing, IHC, which then would give you specific genes to test for? That's the advantage of IHC over MSI, as we've heard. Could you do IHC followed by BRAF testing to select out the sporadics and then go to germline? They assumed an imperfect world based on literature. They assumed that 2 out of 3 people who had colorectal cancer would accept the testing. 52% of the relatives would accept counseling, but of those who do, most of them would accept genetic testing, and that's based on their extensive systematic review of the literature. Long list of costs here. I just want you to see that the per gene cost here was $700 to about $1,000 per individual Lynch gene, MSI about $500, IHC about $260, BRAF test about $100. So just get oriented to the magnitude of those numbers at the time. So what do you find if you take 150,000 people, 2/3 of them agree to have their tumor tested, so or some type of testing, so you basically have 100,000 people. Well, if you institute IHC followed by BRAF, you find 3,340 people in that population. If you do IHC and don't do BRAF, then you find slightly more, but there's also a specificity problem here. So here you have 3,353. MSI, a few more, 3,501. Germline testing, several hundred more. So the tumor tests are not perfect, and if you were to do germline testing on everybody, you'd find more people. But what does this do to the cost? Well, let's first look at the program cost, and arguably a payer might look at numbers like this, because this begins to get at their total budget impact. They sometimes don't know what to do when you talk about cost per life year gained over an entire lifetime horizon. So look at the cost of the program. $41 million for IHC BRAF, IHC alone $46 million, MSI $104. And again, this depends directly on what your assumptions are about how much IHC costs versus MSI. And to do germline testing on everybody upfront with a previous cost, $281 million. Now let's look at the incremental cost per additional case detected. To do IHC BRAF versus not doing it, very highly cost-effective. If you think this number has any meaning, $12,600 per person detected. It's hard to put that in perspective. But all the other ones, the incremental cost for every incremental case detected, extraordinarily expensive by comparison. So this begins to suggest that a tumor test followed by a second-order tumor test to cull out some of the sporadic cases is a reasonable intervention. And I think this gave a lot of wind behind the idea of universal tumor screening by IHC and BRAF. Now let's look at models that have tried to look at cost per life year gained. So the first part of these models is this type of module, as you've seen so far. IRS presented this type of approach, initially looking at how much does it cost to find how many cases, and then the second part of IRS' simulation was, well, what happens later? So these models try to do that. The initial part is finding people, and then what happens later with the probands, and you'll see, hugely important, what happens later with the relatives. This analysis capitalized on a lot of the work from EGAP, and the question here, what is the cost per life year gained when you focus exclusively on colorectal cancer as the outcome of interest for these patients with potential Lynch syndrome? Strategy 1, you do IHC testing for the 4 MMR genes, and if MLH1 protein is absent, you do BRAF mutation testing. Eventually, you get some people over here to MMR gene sequencing. with the order based on the IHC test results. So at the time, you weren't doing a Lynch panel on everybody. You look at the specific genes that are suspect. Strategy 2, IHC testing without BRAF. So you send more people to MMR sequencing. Strategy 3, MSI testing. Here you have to test all genes because you don't have IHC to tell you which are the suspect ones. Strategy 4, everybody goes directly to gene sequencing. And these are the results. Now we're talking about cost per life year gained, where there's a little bit more consensus in society about what we generally pay for in the U.S. $50,000 to $100,000 per life year gained is generally considered acceptable. Many of the things we do are in that range. So here, IHC BRAF, $23,000 per life year gained. That's considered quite acceptable. To omit BRAF results in a lot of additional costs for very little benefit. It's very costly, $274,000 per incremental life year gained over the IHC BRAF strategy. MSI also very expensive. Going straight to germline testing, very expensive. What about if you focus on people under 50, which most of us would say would be too strict an age cutoff? Well, there the numbers look better. They're lower. It's more cost effective to find, to look for people with Lynch among the younger people. But again, IHC BRAF stands out as substantially more cost effective than the additional strategies. We built a model to try to go a step further in several ways. We considered not only colorectal cancer, but also ovarian cancer and endometrial cancer, and we compared the tumor testing strategies to clinical strategies, the traditional criteria, Amsterdam, the Bethesda guidelines, but then also the risk prediction models like PREM, MMR Pro, MMR Predict. And the conceptual underpinning of the model was as follows. You end up with a population with newly diagnosed colorectal cancer, so that was the universe here. You could apply clinical criteria or tumor testing in what we called phase 1, and you would end up with a population enriched in persons with Lynch syndrome, but not everybody is in this initial catch. We know we're missing some people. If you did not do IHC up front, you could do IHC second to try to cone down on the suspect genes, or you could simply not know which genes to target. So you could either end up with persons with possible Lynch syndrome who have targeted genes to test, or just persons with possible Lynch syndrome, and then we would offer germline testing depending on what we knew at the time, and the whole cascade goes on after that, which what happens to the program and what happens to the relatives. As I mentioned, we looked at colorectal, endometrial, and ovarian cancer incidence and mortality and whether intervention could prevent these things. We assigned the costs and the potential harms of doing yearly colonoscopy while assuming the benefit that was observed in the finished cohorts with every 3-year colonoscopy. So here the model is biased against the intervention. We also offered gynecologic screening at cost but no benefit, because there's no evidence that it works. So again, a bias against the intervention, but we offered TAH BSO at age 40. There was the offer of cascade testing for relatives. Many of the inputs came from EGAP, and uptake rates from the literature reflect the imperfect reality. So we are not assuming a perfect world here. We are losing people everywhere along the potential cascade, and adherence with the interventions down the road is far from 100%. So with those assumptions that try to reflect the general reality, this is what we find. So let me orient you to the figure here. I often show these axes in the reverse way that Iris has showed them to you. Discounted life years per person I've been showing here in the x-axis. So the more and more effective an intervention gets, the more discounted life years per person you gain. You'll see that the thing that is farthest to the right here is upfront germline testing. Colorectal cancer, Lynch panel on everybody. But the costs shown on the y-axis here accelerate as we move through the interventions, so that the most effective intervention, upfront germline testing, is also substantially more effective with the costs that we assumed at the time. Substantially more costly for very little incremental benefit compared to the other strategies. Now, the clinical criteria tended to cluster here. The tumor testing strategies tended to cluster here, and then upfront germline testing was up here. Now let's look numerically at how these comparisons go. Well, if we assumed that you could implement the clinical criteria in everybody, and that was at a minimal cost, so you could run the models on everybody in the clinic, and that was actually done, then in general, putting this on the pathology department to test all the tumors was costly compared to actually doing a risk assessment that was thorough in the clinic. It was over $110,000 per life year gain. However, we know how hard it is to institute that. So what was the threshold here? Well, if you failed to implement this risk assessment in clinic in 15% of people or more, then you were better off just asking the pathologist to please do this. And in that case, the tumor testing strategies compared to the clinical criteria tended to cost under $50,000 per life year gained. And it seems to me that it's probably easier to institute a universal approach in a pathology department. Stan talked about all the challenges, but I think it's easier to do that than to do a thorough risk assessment in the clinical setting with complete pedigree and one of the risk prediction models. But one could argue that. So with all of these assumptions, IHC-BRAF emerges as the preferred strategy at $36,000 per life year gain, and this is consistent with what you've seen from other models. So the conclusions are robust, even when you include here gynecologic cancer risk and interventions. What about doing a Lynch panel on everybody up front with the cost at the time? Very costly compared to the tumor testing strategies, so not viable with those assumptions. We've heard a lot about the importance of cascade testing, and in our model, this figure captures it very well. If all the benefit of the initial effort to find a Lynch affected person stays with that person, no relatives are tested, then it's a very, very expensive proposition, over $130,000 per life year gained. But as you bring people into cascade testing, as you essentially amortize the benefit of the initial case finding with the downstream benefits of preventing cancer or cancer death in people who have not yet had cancer, then this becomes a much more attractive intervention from the health economics point of view. And once you get 3 or 4 relatives of the proband into testing, then you're under $50,000 per life year gained. But this absolutely highlights the importance of the cascade testing and getting relatives into testing. You will notice that we are not approaching here a point where this becomes cost-saving. And that's an important point, which I'll summarize at the end. All the work to date suggests that when you consider everything, the effort of upfront case finding and then what happens downstream, it can be highly cost-effective to do this, but probably not cost-saving. So it's probably going to still be a decision by society to say, yes, we invest in this because of the outcomes, not just because of the economics. It's not like we're going to save money with cancers prevented. We are going to invest in better outcomes. There's been a lot of discussion about an age cutoff, and this was our initial attempt at trying to address this question. What if we screen these colorectal cancers only to age 50? Versus going to 60, versus going to 70, versus having no upper age limit? Well, the numbers here in the next column are informed by the Ohio State experience. If you screen only till 50, then you will basically do your tumor test on only 11% of the people. Here, 27%, then 49%, or all tumors. What happens to the number of Lynch people who are in your catch, the people who are in that screen? Well, 57% here, 78, 91, so you have almost everybody up to age 70, but not everybody. If you want to get everybody, you have to have no upper age limit. And the incremental cost per life year gained as you change these age thresholds is shown on the right. If you test everybody compared to testing people only at age 70, that gives you an incremental cost per life year gained that is still under $100,000. It's almost $90,000 per life year gain. You can argue whether this is acceptable or not, but it's under $100,000. Now, a very important caveat here. We did not adjust the potential risk to family members, the penetrance. This is the question that has been in the air through a lot of these talks. Is somebody who is found to have a Lynch syndrome mutation at age 73 conferring the same level of risk of cancer down the road to his or her relatives than if you find somebody at age 60 or 50? We don't know. So we did not adjust for that here. Taking the average numbers, this would suggest that maybe universal screening without an age limit is okay, but if the ultimate yield of finding Lynch in somebody who's really quite elderly, and let's go even further, with a bland family pedigree, if that's different, then these numbers would change. Now you can ask, is there a point at which you find an acceptable incremental cost per life year gained by doing upfront germline testing, especially as testing costs decrease. And we were anticipating this possibility even then. I mean, the cost was going down very quickly for lab-based tests. Well, you can get to a point where upfront germline testing costs under $50,000 per life year gain compared to the alternatives, like tumor testing, if the cost were $150 per gene. So this is $750 for a 5-gene panel that includes EpCAM. You'd be under $100,000 per life year gained when you're talking $400 per gene, and that's $2,000 for a whole panel of the 5 genes. I'm going to switch gears just a little bit here. When you look at cost per life year, you're not assessing the potential effect on quality of life. And we talked about the potential harm that can come from the knowledge of being a carrier, of cancer worry, the burden of testing, all of that. So we actually elicited from patients what they thought would be their decrements in quality of life associated with all of the health states that can be downstream from a Lynch strategy. Knowing that you're a carrier, knowing that you're a carrier and you're considering preventive surgery, having had cancer and now knowing that you're a carrier, all of those states. And when we put in those disutilities, meaning losses in utility or negative impacts on quality of life, and we ask the question, what happens to the cost per quality adjusted life year gain, we saw the following. This really depends on how long this negative impact on your quality of life lasts. Now, most of the literature suggests that people do have a short-term decrease in their quality of life, dealing with these issues, knowing that they're carriers, thinking about their family. But they tend to get back to their baseline after about a year. So if that's the case, if the duration of this disutility is not particularly long, then the cost per quality adjusted life year of trying to find Lynch syndrome in colorectal cancer patients and then doing cascade testing and taking care of their family, all of that is in a reasonable range for a cost per quality adjusted life year. But if somebody really has a substantial decrement to their quality of life for several years, and here you see 3 years, then it is extraordinarily costly because the quality adjusted life years really, really shrink. You're gaining life years, but they're not good quality life years. People are not living in as happy a state as they did before, and you can see that if this is about 3 years of really bad quality of life, then you may be looking at net harm. Then this whole thing may really be flipping the equation. I think this is not the case for most people, but it is a potential problem for individuals. Systematic analysis in the UK concluded that this probably is worth it for the UK, and they concluded that all strategies can improve health outcomes compared with no testing, but the genetic testing for all bowel cancer patients under 50 was not a good use of NHS resources. Now, can we screen endometrial cancers as well? Most models would suggest that colorectal cancers, screening for Lynch there is cost effective. This model suggests that endometrial is as well. The details can be discussed. So these are the insights that I think this offers. It's probably cost effective to do this, but it's not likely to be cost saving. Tumor testing is likely preferred. The gains in life years probably outlive the short decrements in quality of life. Number of relatives participating is key, and universal screen can be cost effective at all ages. Perspective from a payer. I know my time's a little short, but since we're running short in the session, is it okay if I continue this? Okay, yeah, I can do this. So perspective from a payer. Here's the disclaimer. This person agreed to talk to me as long as I said this was a personal communication from an unnamed source working at a, quote, commercial payer. So there's probably little resistance to routine tumor testing, although we heard from Stan that IHC seems to be okay. MSI, they sometimes quibble with. Policies on germline testing tend to follow guidelines, such as NCCN. Policies can take time to come up to date, but they realize that things are changing quickly and they can't always wait for classic large studies as in the past. Their horizon tends to be 1 to 2 years. So they're probably going to look at total budget impact of doing this and not the long-term outcomes. They look for a fair market value for the test and a reputable lab. And what that means, they're not really sure, but does it look like they're doing the right thing? And what about broad cancer gene panels? Well, here policies are evolving. This person pointed me to this website, NextGXDX, where they quote prices for various things. What I'm trying to get at is what are people paying as opposed to what we are charging. This is a fundamental thing in cost-effectiveness analysis. Charges are meaningless because they often don't reflect payment, and it's very hard to get a payment. So quoted price for MSI, $550, for IHC or the second stage test, call us. For a hereditary cancer panel, $990 to $3,300. So here's a panel for a few $1,000s for all the cancer genes. Single Lynch gene, $570 to $1,500. Single site test, $200 to about $1,000. What is this payer paying? This is off the top of this person's head. Don't know about the tumor test. About $950 to $3,000 for a panel. About $500 for a single Lynch gene. $350 to $400 for a single site test. Well, what about another very important payer? Here's CMS. This is one of the contractors, and here's their policy. Well, Lynch syndrome tumor testing with IHC or MSI is considered medically necessary and covered in all people under 70 with colorectal cancer or those over 70 who meet revised Bethesda, or all individuals with endometrial cancer. Okay, so that's pretty good for the initial screen. If you do next-gen sequencing, the standard genes are covered, but XCAM is not covered. I don't understand why. Non-NGS testing platforms, those have to be based on tumor test results and a stepwise approach. But here's the problem. Testing for a specific known familial variant, this is cascade testing, is considered medically necessary and covered only when the individual being tested has signs and symptoms of a Lynch-associated cancer. So you can't test an unaffected relative without cancer who is in Medicare. Now, they put this note. This determination does not imply that this testing is not medically warranted. It's just that the Medicare benefit requires the beneficiary to have signs and symptoms of disease. Coverage of molecular testing for carrier status is considered screening and is statutorily excluded from coverage. That's a problem. You need legislative change to change this. I'm not sure if that's going to happen. So, let's broaden the context and look beyond Lynch syndrome. We've heard about this before. There's cancer genetics in a rapidly changing landscape. I really think this is nothing short of a genomic revolution. We've seen this slide before. Matt's in the audience. We know we can find more people if we test more broadly. The question is what happens. 5.2% high penetrance mutations. Not all of these are Lynch, 3%. Also, lower penetrance mutations and things that we don't suspect. The authors write, to date, clinical practice guidelines have been cautious about endorsing the use of multi-gene panel testing because of paucity of data about clinical utility. But the findings illustrate that genetic factors that underlie CRC extend beyond the well-recognized syndromes, markedly more common than previously appreciated, frequently occur in patients who lack classic high-risk features, and are found predominantly in genes for which specialized risk-reducing interventions are recommended. And this is from Perlman, Heather Hampel, and others. If you restrict this to people under 25, even higher yield, 16%. One of the models said, can we look at the general population, apply the PREM model, age 25 to 35, go on in those who have predicted risk of over 5%. Modest assumptions here about the benefits here because people fall off everywhere along the way. And at this set of assumptions, it's still cost effective to try to find people in the general population. So maybe we need to think more broadly. Now, I'm not affiliated with any of these companies, but think about the numbers we saw before. Look at this now. Invitae's panel, $475 for a patient who doesn't have insurance. List price $1,500 for insurance, but the payer tells me they're paying $950. $249, we've heard this mentioned before. 30 genes, complementary genetic counseling included, $249. So, what are the implications for comparative effectiveness research? Well, first, a cautionary tale. We tried to find people in those coming for open access colonoscopy with a simple tool that Faye Castrinos developed. Endoscopists were told who screened positive. We facilitated referral to cancer genetics, and a questionnaire was sent to these people. So 14% of the people screen as potentially high risk, but 13 of those 14 never get referred by the endoscopist. I'm too busy, I don't want to deal with that. Patients are referred to consult and they don't come. Basically 90% of them. Of the ones who have a consultation arranged, 2 don't show up. In 2, genetic testing is not indicated. 2 decline because of cost of insurance. We find 1 Lynch, 1 MAP, 1 test negative. So a lot of effort, low yield at the end. We were not sophisticated in implementation science, but this was a cautionary tale. So this is what I think we need to look at. For the short and intermediate term horizons, how many probams do we find? What happens to communication to relatives and how many of them participate? What happens in the first round of risk-reducing intervention? What are their harms? What are the wastes? What strategies can we compare to improve the yield and uptake? And I think we have a fundamental choice between the conservative traditional paradigm and something bolder, and this is what Patrick Lynch talked about at the beginning. So on the left, we have the conventional thing. We have people with cancer already. We have the tumors. How do we test the tumors? Do we do clinical criteria? Do we then do focus testing for Lynch with a conventional consent and counseling paradigm? Or do we have an arm in a study that looks at a more liberal use of a multi-gene panel, novel consent and counseling paradigm, maybe telemedicine and others, and we're looking beyond Lynch? I think this is a critical question. So we've gone through the universe, the screen, what happens afterwards, cost-effectiveness analyses, payer perspective, the broader context, which I think is really a challenge to the studies we're going to design here, and what are the implications for comparative effectiveness research. I look forward to the discussion. Thank you very much.
Thank you very much for that provocative talk. Now we are going to have our two discussants, and I would like them both to come up. Oh, Ned first, and then Ravi, and then we'll ask the panel to come up and sit at the table. Now? Thank you. Okay, thanks, Ned. Just push down your 5 minutes.
Wow, that was super. Moving from a lot of science to a lot of numbers that kind of tell us about implementation and considerations that we have to bring to the table in trying to actually implement this. We were given, Ravi and I were given 4 discussion questions. You see them up here. I'm going to take these from a purely public health standpoint. We heard a little from Deb DeCette, who gave us a little bit of public health. I'm going to enrich that from a state public health officer standpoint, which I was for about 9 years in Colorado. And I look at this completely different, right? So when you're in public health, I'm sorry, I have a hammer and everything's a nail, and my hammer is state government. And there may be lots of people who feel that state government has no role in what we're talking about, and I'm going to tell you that public health addresses those things that fall between the gaps, between providers and facilities and insurers, and public health needs to provide things you couldn't buy yourself, like safe food, or clean air, clean water, a system designed to track down infectious disease. So that's kind of the perspective I'm going to come from. So the first question we talked about was, what are the research questions? And the way I look at this is, I need the modelers to give me something else, right? They're telling me about cost effectiveness. I need to know, how many people am I going to save? Right? With all of the assumptions about people not coming for colonoscopy, not finding the rest of the family members, I need to kind of understand the potential upside in terms of lives extended. And I also want some feeling about the unintended consequences. So you've heard a little bit about that from harms, but I would say we didn't talk about a harm of, you know, I have Lynch syndrome, or maybe I have a relative with Lynch syndrome, but I don't have access to testing, and I don't have access to screening if I test positive. This is still true of a certain group of people under the Affordable Care Act, and if we undo the Affordable Care Act, it's going to be a lot more people. And I'm going to tell you, there is a harm associated with telling someone, you have a condition and I can't do anything about it. That's an absolute harm, and we heard a little bit about that. The second research question is, what resources are required for the program? We have heard a lot about cost effectiveness, and I live and breathe cost effectiveness, except in the public health arena. Public health, cost effectiveness gets you in the door sometimes, but that's not the way decisions are made. They are made on total costs. What do I have to get from the General Assembly, right, from their pool of the general fund in order to implement this program? And that's tough, right? So it could be a lot of money. Plus, I have to have people. Oh my gosh, you know, if you've seen one state health department, you've seen one state health department, but we all have some kind of basic rules. And in Colorado, adding FTE is a separate decision than adding money. And so if you don't have the people, but you have the money, you don't have a good program. I need to know all of those resources required. How does the benefit of these resources compare with other, and I'm going to tell you, almost always underfunded public health responsibilities? So this is kind of the opportunity costs. I could do Lynch syndrome, or I could do HIV screening and treatment. And I'm competing for the same number of FTE and the same kind of global budget. I need to do Hep C, I need to do outbreak investigations, and the money that I have is not unlimited. So how do I think about using those resources? And then the research question is what public health implementation approaches are most effective. So we've heard a lot about the healthcare system implementation, and I would say, how do we do this in public health, in that gap area? And I think about the Guide to Preventive Services, who actually talk about, boy, I've identified a service that I know works from the USPSTF, the clinical guide. How do I make that really implemented so that it reaches a maximum number of people? So that I actually have a systematic approach to measure people who are positive in their screening, find the relatives, and get the relatives associated with increased screening. The next question was, what are the barriers to implementation? Well, we talked about resources. That will still be there, but there are also existing policies. And so I will stand here and tell you, not everyone trusts the public health department. Since I've gone to the foundation world, I can use phrases that may be inappropriate, like the black helicopter people. That's this concept that the government is really out to get me and they have no right to know about my information. And it's difficult to create even a health-based system in the setting of people of suspicion and worry. So those are things like existing policies. And then who makes the decisions? Oh my gosh, state legislators. I want you to think about the Affordable Care Act. It is an unprecedented reach into health care in all 50 states. Never been done before. Think about Medicare and Medicaid. That's just payment. The ACA talks about what you have to pay for. And so it's unprecedented. How was it done before that? State health kind of policies. And I believe the next administration is looking back at giving states more responsibility. So who do I need to talk to? I need to be talking to my state legislators. I need to be getting an advocate who's so excited about Lynch syndrome that they will create a bill, find funding, and talk all their friends into voting for it. I asked the question of Dr. Baxter yesterday about who led this. That's so important. I was thinking there were only two answers. One, somebody with Lynch syndrome, right? So that would be one. Or second, somebody who had some other interest, like a gastroenterologist. That's key. And so if you're thinking about this in trying to implement public health support for what I think is an important thing to think about, how do you get the policymakers' attention? And then I'd love to tell you that the healthcare system and public health work seamlessly together. I can't believe anyone in the room believes that, right? In fact, there's a tension between public health and the private healthcare system. And so working through those issues is important. And there are successes, and I point to newborn screening, where most babies are born in hospitals, and there's a system at the state health department that takes the blood spots, does the testing, and reaches back out to primary care providers to say, these are the test results. That's a huge success. Newborn auditory screening, similar. Infectious diseases, following up in other healthcare systems. So we have successes that I think we could really learn from. How do we overcome the barriers? So you've heard about these through the thing, different healthcare settings, geography, rural settings, and underserved population. We talked yesterday about life and health insurance. We've talked about the accessibility and availability of genetic counseling services. These are all things that we need to overcome. And I guess as I thought about it, is that the blue ribbon panel, the moonshot, needs to create a shared emphasis on screening and coordination for Lynch syndrome if we want to have an effect. It has to have advocates and champions in all different kinds of settings, and they have to be coordinated, and we really ought to be thinking about that big picture. I just gave some examples. Engage the hospital QI processes and medical staff. Convince them that, boy, you have a colorectal cancer patient that comes in for surgery, you ought to be thinking about how to make sure that person is tested for Lynch, and then kind of what you're going to do with the information. You heard about providers, supporting provider education. There's lots of places. We could talk in medical school, graduate medical education, and CME, and these are issues that public health can interface with if we work with the right champions. And then I was trying to think about the system, and tumor boards are still around. They could be engaged around, did we test for Lynch? Malpractice insurance providers in terms of making sure that we follow through with the standard of care, public campaigns. I just think there's a lot of approaches that we could do to create this unified, excited approach to Lynch syndrome. Then the hammer. I think you ought to think about state laws. We do this all the time. Legislators love to spend somebody else's money. I mean, it's like, not tax dollars, somebody else's money. So you say, health insurance providers, you have to pay for screening. You have to pay for genetic counselors, and you have to have data sharing around this issue. And those are all possible. It's not like it's impossible. You need those champions. You need a real person that's working for you. Our next question was facilitating shared data from different settings. So Greg answered that. It's going to be hard, right? How many people know what a RIO is in the room? Yeah, 1, 2, yeah. This is George W. Great concept that it stands for Regional Health Information Organization. And the idea is that we would start getting these EMRs to talk to each other and share critical information across systems, right? I think there's like half dozen of them still in place. Colorado has 2 of them that don't get along. But the idea is that you could think about how to use something around the EMR like Greg was saying to really make this better. And then there are other public health strategies. So I thought about this one. This is really kind of clever. You make Lynch syndrome a reportable disease. All 50 states have a reportable disease list. And you can add to it either through rule or law. And if you say Lynch syndrome is reportable, that means every time someone tests positive, it has to be reported to the state. And then you actually have a registry of Lynch syndrome positives. What you do with it from there gets to some of the other barriers, but it was a very intriguing approach. Certainly, you heard a lot about registries. Make Lynch syndrome test results, or whether or not it was even tested, a field in SEER and state health department, state cancer registries. I mean, I know that it's a huge implementation issue, but it seems so simple to just say, add a field. This is so critical that we need to make sure that we're gathering those information. And then once you have the data flowing in, work on the notification system for results. Think about newborn screening and infectious disease. How could you develop a system of notification for providers who might be taking care of family members and a notification system for family members? I want to pause just a second. Remember, there's 2 people in the exam room, right, that you can motivate. One is a physician. Present company accepted, I gave up on that years ago, right? It's hard to change physician behavior, sorry. But the other is the patient. And thinking about strategies and campaigns to activate the patient. We've had good advocacy groups here. How could we say colorectal cancer? I mean, there's this great, Oregon took on something called a public will building campaign just for colorectal cancer screening, the test that nobody wants, right? Still only 1/3 of people eligible in the United States get screened for CRC. So let's bring that up. Well, as long as I'm doing a campaign around CRC screening, just slip in another question about might you have Lynch syndrome? Might your family members have a higher risk? The last question was, how could public health programs and healthcare systems partner for maximum impact? when I first looked at this, I said, well, I don't know. But I think, yep, this is my last slide. So required reporting, shared data, systems similar to newborn screening and infectious disease have outreach to the healthcare system and families. They've all been effective. We can do this. It's not impossible. And, you know, I have to say, public health can help. And then I have to say this area will be new for most public health agencies. Deb, why are you doing this in, it's because CDC gave you a grant. Oh, you were doing it before, that's right. Champion, right? The other 4 are doing it because CDC gave them a grant. That's 5 out of, we heard yesterday, out of the 50 states. CDC is not going to have the resources to provide this for everyone, so I think it has to be in the state system. And follow the approach for all other conditions that require public health support. So that's the public health look, and now I think Ravi's going to look at it from the healthcare system and an academic standpoint.
Thank you, Ned. Ravi Sharp. Thank you.
Thanks. Thanks. So Ned and I addressed the same questions, but my perspective is from the healthcare system perspective. I think if you're talking about Lynch syndrome screening, that necessitates a discussion of Lynch syndrome management and genetic testing and counseling, as well as the hereditary cancer syndromes in general. And one thing just to note is that a lot of the themes that are going to come up were also discussed at an NHGRI conference last fall, the IGNITE conference. So there is overlap. So I posit 6 research questions that have to do with the implementation of Lynch syndrome screening. I think if prevention is our goal, what are the optimal strategies of risk stratification to identify those with inherited cancer? And that can mean anything from family history uptake to, you know, population-based germline sequencing of whatever manner. And do these strategies translate to appropriate cancer screening and improve clinical outcomes? For those diagnosed with colorectal cancer or endometrial cancer, what are the optimal methods of screening for Lynch syndrome? And I think, you know, that ranges from clinical prediction rules to tumor-based testing to germline sequencing. And as Yuri had alluded to, I think cost is going to be a big factor in that determination. What are the optimal methods for provision of cancer risk assessment for a healthcare system? Greg did a really nice job of illustrating a lot of the contextual factors that are involved, and I list some of them here. And how do these contextual factors influence the successful implementation of Lynch syndrome screening? Alana Ram from Geisinger is an expert in this field, and so I'm looking forward to her insightful commentary during the discussion. No pressure, Alana. And then the last question, I think, is we need further clarification as to the natural history of Lynch syndrome and clinical care. And Yuri did a nice job of elucidating some of the evidence gaps in the field. So what are barriers to implementation? You know, number one, genetic counseling and cancer risk assessment services tend to be viewed as revenue losing and at best revenue neutral, and so healthcare systems are going to be hesitant to invest resources in such areas. And right now there are no pay-for-performance genetic metrics. Greg talked about publicity a little bit, and right now there is not much, you know, and providers don't know much about hereditary cancer syndromes. There also are workforce issues as well. For informatics, you know, it's hard to find a clinician that's going to say something nice about the EHR, and so in solidarity, I won't either. You know, for technology and its implementation, it's outpacing the evidence. So what do we do? You know, I strongly believe that genetics will come to the forefront of healthcare systems when it's aligned with the needs of a given system's C-suite, and so that means that the CMO, the CFO, and the CEO, and I think the way to do that is to tap into metrics of recognition and reimbursement. For under recognition, you know, I don't want to afflict her with yet another hereditary syndrome, but the Angelina effect for BRCA1 and 2 is known, right? And we need our own public advocate and our own public spokesperson. A public health mandate would be really nice as well. That alluded to HIV, which I think is a provocative comparative example in terms of mandatory reporting, in terms of prevalence and transmission. System-based interventions for QI are by far the most durable method, and Yuri had mentioned universal screening and what that means. And, for example, if the whole paradigm shifts and we start doing somatic sequencing on all cancers, that's going to change recognition and the barriers associated with that. For informatics, I would love to have a structured field in the EHR for genetic data. I would love to have complete and accessible family history information, and I think we need really good clinical decision support. And then ultimately what we need is good comparative effectiveness research and dissemination and implementation research with a focus on disparities and patient-reported outcomes. So how do we facilitate data sharing? I think from an infrastructure perspective, we can model after established cancer registries. Yesterday we talked about SEER. The Cancer Research Network and the Virtual Data Warehouse is another example. The international country-based Lynch registries that are in existence. I think NCORE sites can be a foundation for data collection, and not to be a broken record, but structured fields in the EHR are fundamental for retrieval and reporting of genetic data. And the last thought I had about public health and local partnership, I think Ned did a really nice job here, but public health agencies can foster local partnership via regulations and via promotion of quality improvement and research. Yesterday we talked about the latter with the CDC state collaborations. One example of that on a state healthcare system level is in New York, where the Department of Health is fundamental to allowing hospitals to get their genetics programs up and running. I don't think it needs to be top down. I think it can also be a two-way street, such that local advocacy can influence public policy. The local example we have at our healthcare system is where a patient stakeholder with Lynch and one of our outstanding genetic counselors, Sharona Cohen, basically petitioned Andrew Cuomo, such that now March 22nd is Lynch Syndrome Day in New York State. So it just speaks to the ability of stakeholders at all levels to improve recognition and get our patients the clinical care they need. Okay. Thank you.
Thank you, Ravi. Okay, I see that we have a lot of people who've held their questions, and I thank you for that. And would you mind announcing yourself first so that it can be recorded? Thank you.
This is not working? Not yet? Okay. Can we activate this? All right. If I start speaking, will it work? Yes. Muin Khoury from the CDC, Office of Public Health Genomics. You heard me yesterday. I want to thank the whole panel. Although Greg started by depressing me, I ran to him after his talk. I said, Greg, why don't you prescribe me some Prozac, because I need it. I've been doing this at CDC for 20 years after we created the Office of Public Health Genomics that has been really working around that interface between public health and healthcare. I want to make a couple of comments because everything that needs to be said has been said. It's just that, sometimes the action is a bit unclear at that interface. And our departing director, Tom Frieden, who recently departed as a result of the election, had this, what he calls the health impact pyramid. In order to make a difference at the population level, there are like 5 steps. At the bottom of the pyramid, you work on socioeconomic. In fact, whatever the health problem is, if you start at the bottom, you impact more people. And at the top of the pyramid is sort of clinical interactions. Sort of you impact one person at a time. You need to change the system at the bottom, which usually refers to policy work, things like making Lynch syndrome a reportable condition, advocacy, reimbursement, and all of these things. So if we apply that work at that interface, we know that there are recommendations, whether or not Maine, for example, wants to implement them because they may or may not see a single case of Lynch syndrome in a particular year versus, working at the base where you reach everyone in an equitable way. And the main example I have, which has something to do with genetics, is newborn screening. And think about newborn screening, which started more than 50 years ago. And we started by 50 states, one at a time, and then it became more formalized. Now there is an advisory committee that, deals with the a universal recommended panel that has more than 30, mostly genetic conditions. But it started with PKU. Think about PKU. Every year, we have 400 babies born with PKU in the whole country. How many cases are born in Maine, Greg? Maine probably was the last state maybe that adopted newborn screening because you don't have cases. But, you know, it works, it saves lives, it saves brain IQ and developmental disabilities, and then the number of conditions started adding. Now we're talking about a few conditions that affect mostly adults, early cancers, I add heart disease to this, where we're dealing with at least 2 orders of magnitude bigger in terms of impact than what we could catch in the newborn screening arena. So we have about 2 to 3 million people with these highly penetrant genetic conditions. So if we think globally about how to reach as many of these people as we can, I mean, we heard some of these solutions. Advocacy is important, champions are important, and you know, coming back to Michigan, Michigan started long before we gave them any money because they had a champion within the health department who recently died. Her name is Jean Chabot, who really pushed the envelope in the state of Michigan. But others, you know, depending on the situation, may or may not increase. So the fragmentation and the ease of implementation have a lot to do with actual implementation. I mean, you've seen these numbers, and it's a complicated schema, but every state has a cancer registry. And wouldn't it be nice if of the 150,000 cases of colorectal cancer diagnosed every year, that the 6,000 or 7,000, 5,000 or 6,000 of the ones with Lynch syndrome get flagged, you know, a field that says this is Lynch syndrome. Because if you start there, then you can construct the cascading that's needed, and then the advocacy.
Do you have a question, Muin, for the panel?
The question is, yeah, I mean, I'm
sorry.
Here, of course.
I'm trying to be mindful of other people.
I appreciate that.
Okay.
Question to Greg, because Greg is the embodiment of sort of real-world practice in genomics. You live in Maine, and you've tried to deal with the health department. So give us your experience about that and some of the, you know, the pros and cons, because they screen newborns, don't they? Even though they may not see a single PKU case in a particular year. So just help us walk through the mechanics of what would it take to get to a Maine public healthcare interface. And I'll shut up, then maybe we can.
Thank you, Muin.
Taking too much.
We appreciate it.
So a number of years ago, actually when I had left NHGR, I did approach our state public health department about the topic of hereditary cancer syndromes, not just Lynch specifically, but the hereditary cancer syndromes. You can't hear it? Okay. Okay, so I did go to our state public health folks. I talked to the genetics officer for the state. I talked to the cancer registry folks, and really about the idea of creating a statewide cancer registry focusing on hereditary cancer syndromes, because in my mind, we have 1.3 million people. We should be able to wrap our arms around the entire population relatively easily. There's not a lot of immigration and emigration in the state. We have fairly strong family systems, although with rise of the opiates, that's sort of broken down a bit in our state. And it came down to really a resource issue and an issue around legislation and politics. So the registry folks were very pessimistic about the possibility of expanding the kinds of things that the registry collects across the state. They felt that the legislature would need to be involved, and you may have noticed we have a rather colorful governor and a fairly contentious legislative divide in our state at this point in time. It's gotten better, I think, with the election, curiously enough. That's kind of interesting. But so I actually tried to bring in from Muin a couple of interns to our state's genetics department and for a summer to work on the topic, and they refused some FTEs because they didn't have computers and seats for them in the genetics program. So, you know, there are real challenges. I sat on the committee that worked on implementing SCID screening, adding it to our newborn screening panel. It took about 2 years for that implementation to work through. One of the major hang-ups is, what did you do with the people who actually didn't have SCID but had some sort of T-cell abnormality that you couldn't figure out what it was, and who was going to see them? Because we have one person basically in the state who can see those folks that screen positive that probably don't have SCID. There are real challenges in a resource-poor environment for this, and it's not that the folks aren't interested. They just, again, opportunity cost. They've got a long list of things they're expected to be up to, and adding one more without some new funding source is a real challenge.
Yeah, that is the reality. Yeah, thank you. Yes.
Hi, Pat Lynch from MD Anderson, and my question has to do with managing expectations and the circumstances of genetic exceptionalism. So many of the elements in the modeling as we follow and we have follow-up have to do with managing expectations of patients. So what proportion are willing to have this test, and depending on that, what proportion are willing to go on and have that test. And it's my view that as clinicians, we manage patients' expectations all the time. And it may seem kind of paternalistic, but you know, we've kind of learned to live with that, and so have our patients. When we present something as something that is considered medically appropriate and we recommend it, and of course you will do this, there's not a whole lot of pushback. And I think in trying to develop any sort of an implementation model, there are many inflection points where, depending on whether you view it as an expectation that something will happen as part of clinical medicine, as opposed to something that we have to get an IRB protocol and an elaborate informed consent mechanism around, you'll have markedly different outcomes. And one good example of this, and I'll ask for views on this, when I was visiting in Adelaide, the group doing their facilitated outreach to families, I asked them, so, you know, what is the role of the index patient in reaching out to relatives? And they simply said, well, we pitch it as an expectation. We encourage you to talk to your relatives, but really it's our preference as a health ministry, it's our preference that we do this for you, and there's really no pushback at that point. They do that. So at the ultimate level of managing expectations, a state mandate, you basically say, well, newborn screening, you're going to have it done. There's not really a whole lot of opting out under that circumstance where it's an expectation. So I guess my question is, from the standpoint of some of the modeling, where might you view inflection points that we can really make a difference over in terms of the percentages and the fall-off by viewing somewhat differently what the expectations are and how we can guide that in our healthcare process at each stage of the game?
Yeah.
Yes, thank you very much for that question. I think it's an excellent comment. I think that there were, if you remember the flow diagram going down, that there were a lot of places where we lost patients and therefore potentially lost the benefits of the downstream testing, which for the model is very important. And I think that getting in after the IHC testing results are available, that part is where you lose people, and if you sort of bring that differently, I think that would be a good case. On the other hand, you do not want to be too paternalistic, given that this is a balance between harms and benefits, especially for the index case to start with, to whether he or she wants to know that or not. So I think that it's different from where you know that a treatment will be of benefit. There are some downside harms with this that I think should be informed. With respect to reaching out to the family members, I think that's especially a place where you can reach a lot more people if it's done not by the patient because of all the issues that were discussed yesterday. And I think that the yield could be much higher. I think I was talking to Heather yesterday that in some familial hypercholesterolemia study in the Netherlands, they were finding 25 probants rather than for the study that we've also done in the Netherlands, but then for Lynch, we were only finding 6 family members. So that can make a big difference, how much effort you put into it. And I think that that's probably also more reasonable to be paternalistic about that, because it's other people you're talking about and not the patient itself that you want to make sure that he or she makes an informed decision.
We are running up against a break, and we have 4 people. So it's okay to keep going? Okay, so yes, please answer. Sorry.
So I was just going to put in a comment about the idea of sort of the bottom of the pyramid and system-wide changes, and particularly sort of enacting change through legislative efforts. The organized medicine is not particularly keen on medicine through legislation. And that's because you're one group of advocates for one small slice of healthcare, and there have been some really remarkable sort of examples of egregious activities, particularly in the newborn screening world, where, you know, extremely rare diseases get pushed to the fore because the stories are so compelling, and really at a population level make no sense, but it ends up being an unfunded mandate to the healthcare system to tackle it. The opiate issue is another example where, you know, medicine is happening in Maine by legislation right now, and all of the reporting that we're required to do, the additional training that we're put under, comes with no additional resources, no expectation from insurers that they're going to pay us more to do these things. So, you know, we can't make medicine work by passing legislation, which often comes without any resources to enact at the level of the healthcare system.
Just one quick comment on your question, Patrick. I think areas we agree that to change the numbers in the model is easy. So that can be done. And then you can say, what if this, what if that? It's much harder to make the on-the-ground changes that you're talking about. But maybe the way that the two things come together is that the models can give us some indication of where pushing might really make the biggest difference. In other words, it's probably a much higher yield to get somebody to do their genetic test in the first place and talk to their relative than to do a colonoscopy every 2 years instead of every 3, for instance. So clarification by the models maybe can help actions, but changing the models is pretty easy.
One brief comment about that, too, is I think Yuri's mention of uptake and adherence is really important, and that is an inflection point that we often miss, and something that models can benefit.
Thank you. Yes.
I may make a comment rather than asking a question. In terms of the demonstration project, the comment is, I think this is missing the point that the shift has already occurred in the testing of colorectal cancers and endometrial cancers in the general population. And the evidence for that comes from several perspectives. One is patients who are referred to our institution, I would say over half of them already have MSI testing or immunohistochemistry done on their tumors that are referred in for treatment at our place. Secondly, in the National Clinical Trials Network, the MATCH trial, the majority and probably the large majority of colorectal cancers patients being referred to that trial have already had MSI testing or MSI testing. And thirdly, if you go back to the adjuvant trial E5202, it was done in stage 2 colon cancer, closed about 4 or 5 years ago, 2,834 patients. And what we saw during the course of that trial was a marked uptake of patients who had already been tested before they were referred for that clinical trial. So the focus here needs to not be on whether it's going to be tested or not. It needs to be, what are we going to do with the information that's going to already be coming? And again, I don't claim that the 4 professional organization guideline is going to change the whole practice of medicine. But the fact is that is out there, and the testing is not simply for Lynch syndrome. It's also a prognostic marker. It's a predictive marker for immunotherapy and for the decision-making not to give adjuvant therapy. And as you heard from Frank, there's a clinical trial now with MSI in stage 3 patients where at the moment the recommendation is that everybody gets treated. It will answer the question of whether it's worth doing or what the chemotherapy selection is going to be in patients with stage 3. So what I think you're going to see is that, you know, you're already have a vast majority of patients who have already been tested, and the demonstration project needs to address the question of how are we going to deal with that information, not whether it should be done or not.
Thank you very much.
I think that's an excellent point, and I think what will happen based on that is that this testing that we're now currently taking the costs into account into our cost effectiveness analysis, actually those costs will not need to be incorporated for the universal Lynch testing anymore because they're being done for other reasons anyway, which will only make the cascade follow-up much more cost effective and therefore probably could be in the direction of cost saving maybe even.
David Rantzoff, UNC. I've loved this discussion about opportunity cost, policy, wonderful big picture stuff, and I'm a little embarrassed to ask a pointy-headed modeling question, but I want to because that drives policy so much. And it's Iris, in your modeling, you made some assumptions that really drive the goodness of this very frequent colonoscopy, whether it's 2 years or 1 year. In one of your early slides, I think you said there's a 10 times normal rate of growth and a 2 times normal development of adenomas. And I would wonder, is that backed up by strong evidence that these lesions grow so fast? And I'd ask you or maybe Patrick or Stan Hamilton or Rick Boland, it might be something to discuss, but that's a huge driver of the conclusion that you end up with.
Yes, so thank you very much for that excellent question. I think that's where we really lack a lot of data. I've done modeling before, originally for the Canadian situation, where I, instead of doing a faster progression, only looked at a higher rate of adenoma onset. That's probably definitely not the case, but it would become even more cost effective. I've looked at where I assumed twice the progression rate and then a 10 times higher adenoma onset. That again, it would be more cost effective. So I've tried to choose in what I presented to you today to be as conservative as I could for universal testing and still found it to be cost effective. And so if you look at the other models, if it's not growing as fast, it means that it's only going to be more cost effective, but annual versus biannual in all the scenarios that I looked at least stayed very cost ineffective. Question about opportunity costs definitely stays, and I totally agree that there's always prioritization. What we try to do with cost effectiveness analysis, we cannot take into account the whole world, but by using the same threshold for all interventions, you at least try to get at a certain prioritization good value for money.
Thank you.
John Newcastle, just to reinforce Stan's point, the slide I flashed past yesterday is a very high throughput MSI test which could incorporate BRAF in the same assay. So the cost of goods would be less than immunohistochemistry, depending on how much markup you want to add to it, but the cost of goods would be down to $35 to $50 range. So I think MSI testing moves up the agenda because of that. But what I also wanted to draw attention to was no one's talked today at all about aspirin. I only had a few minutes yesterday, but the evidence for that outside of our study is enormous. And so one of the questions we have to ask is, what are we doing about aspirin in this population? Are we moving towards getting it as an indication? Because the effect against cancer is dramatically better than the effect against cardiovascular disease. And so we've already got this task force moving in that direction. Is it possible that NCI could actually sponsor a co-production with the advocacy groups of comparing standard aspirin to cardioaspirin, self-medicated, to sort of try and think of some new models to get this up to scale, because giving people not only surveillance but giving them an intervention does make a difference to people's reaction.
It's certainly something that we can take under consideration when we look at all of the recommendations that have come out of the panel.
Hi, so Alana Rahman-Geisinger. I want to make a comment and sort of an observation since Ravi ratted me out. So I want to say this 2 days has been amazing. I'm really optimistic because we have a grant actually that was under review panel yesterday at the DNI panel with Ravi and Jessica and others, my fellow Lynch Syndrome Screening Network board members, to actually study the first 3 questions on this section of the panel, and to really understand across multiple healthcare systems, what are given your system, your structure, your costs, your providers, your patient population, to use Gregory's words, are you on the moon or the beach, and what is going to work in those contexts to help you implement Lynch syndrome or other precision medicine programs, should you even try, or is it not cost effective for you at this point in time? But what I want to say in regards to that too, though, is we have to make a conscious decision to look at this. That also requires, if we want to answer these questions, it requires time and effort and research to look at this and to try to put this together, to put together a toolkit or whatever it takes to help not only do Lynch syndrome screening, but to use it as the tip of the iceberg as our use case for other precision medicine programs. So that's just my observation, and I will get off my soapbox now. Thank you.
Well, I certainly hope you had a kind and gentle review yesterday.
Thank you. I'm Lainey Linder from Mayo Clinic, and I wanted to just throw out a couple of ideas, and I'm kind of leapfrogging downstream to some of the patient-related issues. The idea of having Lynch syndrome being a reportable disease to the health department has some appeals, but it also risks stigmatizing people with genetic conditions. However, I think a really nice integration of that would be if you worked with the Lynch syndrome community and individuals diagnosed with Lynch syndrome through their genetic counseling services. Oh, I'm just too tall. Through their genetic counseling services could choose to list themselves with a public health service listing, and could also then potentially the public health service could tap into the notify the relatives thing as they might do for HIV or some of the other communicable diseases, because it's similarities that way. So I throw that out there and wonder if there are major barriers for that. The second idea or problem that I'm kind of thinking about is the people that you identify with Lynch syndrome who have no health insurance to follow through on their recommended screenings. And would there be a way to incorporate these individuals into Medicare or some other coverage at a national level to say, we've identified you through this moonshot project, and if you meet some sort of economic threshold that we will cover the screening related to the diagnosis that's been unearthed. So any thoughts to those ideas? I'll never again have this audience here to say this to, so thank you for listening.
Thank you. I'm going to ask Ned to address this question.
So thanks for the question about stigmatization. We ask that question for absolutely every reportable disease, and probably doesn't give you much comfort, but I think the public health system feels like it's done a really good job of not sharing that information in a way that would stigmatize a person. I think the idea of including Lynch syndrome groups in how that would be implemented is just so key. I would never think about doing it without that outreach. And the good news is it is a public process, and so that would have to be included. I do want to say one issue about opt-in and opt-out. I don't know how Lynch syndrome would work out, but I will tell you that universally opt-in systems underreport, universally. So, so you lose a little bit of the benefit, and I think your question is really important. It's that kind of, what's the does the benefit outweigh the potential harms on the other side, and that's the way we look at all public health interventions. The last issue is it depends, right? So Medicare may not ever get excited about dipping below 65 into screening for people. Medicaid might do it for low-income people, and the Affordable Care Act could do it. There's actually a way that it could happen. It's just who knows what's going to happen with the first dollar coverage of screening services under the new administration.
Yes.
In San Diego. When John Byrne mentioned, and I had forgotten about this, that he has this new approach to go back to measuring microsatellite instability in BRAF first instead of immunohistochemistry, it just got me thinking about what I assumed that the real object of this, my reading of the blue panel, the blue ribbon panel charge, was to find precision prevention, because we can't implement something unless we know what it is that we're going to implement. I mean, we got to do that first. We don't set up an implementation and then now we'll figure out what we're going to do. And so I think that what's going to happen is 5 or 10 years from now, I think we're going to be doing something very different, and I think that Ilse and Yuri are going to be twisting the dials madly on their models, because I think that we're systematically missing something with immunohistochemistry. I think there's something wrong with our reading of MSH6 and PMS2 that gives us a very skewed inaccurate view of what's going on. And the way we should manage Lynch syndrome, MSH2 and PMS2, or MSH6 and PMS2 is completely different than the way we should manage MLH1 and MSH2. They act pretty differently. It comes back to this issue of penetrance, when we start, how we might delay initial screening, how we might get some other kind of testing, maybe fecal DNA or fecal immunochemical testing or FIT testing. I think that that's all going to be different once we really figure out what we have. And I think that maybe by doing MSI testing first will really change things, because the universe of Lynch syndrome patients will look really different. And then once we understand penetrance, once we understand the variable expressivity, then we can determine what we'll do.
Thank you.
Rick, just one quick comment. When we did the technical review for the AGA on some key questions, one was what's the sensitivity and specificity of MSI and IHC? And delving through all those papers was a nightmare, because they're all full of all kinds of technical issues. But you're absolutely right that many of those were based on finding MLH1, MSH2. And so the inputs to our model for sensitivity and specificity may not really reflect the reality with increasing recognition of the higher prevalence of the other genes. So I think that's very true, and it could change the inputs. And then to John Byrne's point, if we change the cost, then the order of the strategies absolutely changes.
Yes, and to add to that, I think that's indeed where the modeling can help. It means that we would have to change some assumptions, but I think that if there is good data out there, then that we can address those questions and really compare. And then Europe, I know from experience, Europe does not necessarily represent the US or the other way around. And so test costs differ from country to country as well. So what we can do cheaply in Europe may be expensive here and the other way around, depending on manufacturers.
Thank you.
Finley McRae, Melbourne, Australia. 2 points. One is, in our compulsory cancer registry, we do have the provision to compulsorily register familial adenomatous polyposis based on pathological observations of surgical specimens. So I guess there's a lead in there that's a little easier than Lynch syndrome, but it does represent an example of compulsory registration of familial gastrointestinal cancer syndrome, and that can translate to engagement in the familial cancer clinics. The second point is just to use the opportunity of this audience to advise that the Insight meeting is going ahead in Florence early in July, 5th to the 8th of July in Italy, and you'd all be welcome to attend. Thanks for the opportunity to promote that.
Thank you for that announcement. We have one last comment here.
Neil Perlman from Cure Lynch Syndrome, which is a health advocacy group. The question has to do with universal screening. If you create a registry with GINA, the Genetic Non-Discrimination Act, it doesn't cover life insurance or disability insurance. So by registering people, you'll be putting them, putting people at risk of not being able to get life insurance at a good rate. Is there any thought about that?
Well, I'm sorry, I only have my own experience. That information isn't available to other parties. So public health data actually has very strong protections, and so an insurance company actually can't get results of your HIV tests, right? Now, insurance company might test you for HIV as a pre-screening approach, but that's their job. So if we create a registry in Colorado or in Wyoming or Utah, that information is not available to life insurance companies.
But the question is, if they ask, do you have any hereditary conditions? And now that you know about it by being tested, you're then discriminated against.
Yeah, so we're going back to the legal discussions yesterday. So I think that's true anytime we're going to test for hereditary cancers, and it has very little to do with the registry. It has to do, I mean, wouldn't you answer the question the same way you'd either disclose or non-disclose if you knew you had it, whether you were in a registry or not?
Yeah. I would just add that I would think that we would need a lot of public discourse about the idea of adding conditions that have generational consequences to a registry. In that, to this point, you could say infectious disease certainly has familial effects. That is generally restricted in time, whereas 4 generations from now, that data that's in a registry might have impact. So that's I think that's a concern for me, is just moving forward. We've seen the arguments about blood spots and retention of blood spots at the public health departments, and very different views on privacy and security around those. So I think you'd have to have a lot of conversation about that idea.
Very good.
I agree, Greg. And so just to follow up on that, there's been this discussion, right, about, well, why don't we just do whole genome sequence on all newborns? Why don't we replace all newborn screening with whole genome sequencing? And the issues you talked about and the advocates would say you only have to do it once. Right, so once you do it, you have that information and follow you through time. That phrase, follow you through time, that I don't know actually how to do that. And the ethical issues, et cetera, and who has that information, I think you're exactly right. So yeah, it's easy to stand up and say, let's think about it as a reportable disease. But I think the implementation and the ramifications and the ethics are really very important.
Oh, one more question.
In the discussion of cascade screening, we've thrown out a lot of costs as far as what it costs to test the individual versus family members. The lab that's doing the testing for $249 now will test family members of individuals who have a known mutation for $50. So that is, if we factor that type of lowering cost, I think it really impacts the numbers that have been discussed here today.
So I'd really like to applaud and thank this wonderful panel. It's been a delight working with all of you, and I think you've provided a very diverse opinions and thoughts on a difficult topic. Thank you very much. And now we have a break. No, we don't have a break, excuse me. But you can all stand up. I think that might be a good idea. This has been a couple of hours. Thank you.